died because of their pregnancy. Dr. Michelle Owens is going to speak. Dr. Owens chairs our Maternal Mortality Review Committee, which is very instructive in our work and helps us understand the causes for excess maternal death in our state. I'm going to defer a lot of this information to her. I do want to publicly thank her for leading our Maternal Mortality Review Committee work, which is extremely difficult and very difficult at all levels, but certainly difficult emotionally and spiritually as they are dissecting each one of these deaths in Mississippi. Thankfully, we have gotten those deaths below 50 per year. That is still too high, and we will continue to work on improving maternal death. But really our challenge today with maternal health is making these pregnancies healthier so that her outcome is better and that the outcome for the baby is better. Here is the mortality, the infant mortality rate trend since 1950. When you go back and look at the number of women who have died unnecessarily related to their pregnancy since 1950, it's a little over 1,000 women who should have survived, who have not since 1950. When we look at the babies, that number climbs to over 23,000. If you look back into the 1950s, we were losing over 2,500 babies per year in the state. We have that number down to around 350, but that is still an incredibly world. And I do want to point out, if you look from the mid-60s to the mid-70s, you'll see a marked decline in infant mortality in our state. That is not because medical care got better. It's not because NICUs were saving babies. They really weren't very well developed in those decades, but it's because of things. One, the implementation of vaccines that markedly reduced the rate of infant death in our state from over 2,000 a year to now down to 350 a year, but also in 1970 with implementation of Medicaid. So Medicaid and vaccines have saved thousands of babies per year, and that is historical fact that we do not need to forget. Here specifically relates to the infant mortality over the last 10 to 15 years, and you will see that we're doing better than we were doing in the late 90s and early 2000s, and we continue to improve into the 2010s, but then something has happened, and over the last 3 years we have been going the wrong direction. And the reason for the public health emergency is when we received the 2024 data and we saw we had a significant increase back up to right at 10 per thousand live births. We were at 9.7. That is an alarming number, but it was the highest mortality rate for our babies we had seen in over a decade, and that is despite all the good work that is represented by so many experts and community-based partners that are in this room. Despite the millions of dollars invested, the heavy work that's been going on, our infant mortality was moving in the wrong direction, and this is even more alarming. If you will look at the upper left quadrant, you will see African American infant mortality, and it exploded in 2024. And in my estimation, when we're already the worst in the nation, and we have our worst year for African American babies, that is a public health emergency. And we cannot allow state government processes to get in the way of doing what we need to do to save these babies. Now, public health the Joint Public Health Committee hearing next week will have an hour to go into a full deep dive into what's going on as best we can see it here. I don't have time today to go into it, but it's important to know half of the deaths of our babies occur in the first month of life, and half of those deaths occur in the first week of life. And that is directly related to maternal health or lack thereof. These are moms that thankfully are not dying, but their pregnancy is unhealthy, and it is causing preterm low birth weight babies to be born that just cannot survive. In Mississippi, if you give birth to a 22, 23 gestational week baby, that baby has little to no chance of survival. We do not have a teeny baby unit in our state. There are states that do, and babies of that gestational age, can be rescued, but we just don't have that capability even at UMC. So half of our babies, their deaths are directly related to poor maternal health. These are pregnancies that are causing the babies to be born early and at a low birth weight, which makes them extremely high risk for death. So this is, as you were really studying maternal health, you cannot disconnect it from infant health and infant death. And that is why you see an excessive number of babies dying versus the moms dying. Now, if I had the data for every form of poor maternal health, all the things that cause high-risk pregnancies, you would see a gigantic number. And yes, the African-American community is disproportionately impacted. But this number right here should get all of our attention. And when I present this data, irrespective to the group, it is alarming to everyone. We cannot allow a system that is generating a mortality rate among black babies of 15.2 per 1,000 live births. That is just absolutely unacceptable for our society. This is important for you to look at as you have time. This shows you by counties where the highest mortality rates for the babies are. We also do have it for maternal. I can't report by county for maternal death because the numbers are too small, but we can report it by region. But when you look at maternal death, certainly the Delta has the highest rate. Southwest Mississippi, Northeast Mississippi have come in behind that. But the number of deaths of our babies is high enough that we can report it by county. And so you can look at the counties that you represent, and you will see the 5-year aggregate mortality data for your counties. I also have for you a breakdown by region. We have 4 public health regions: the North, Central, South, and the Delta region. And this will point out for you our true obstetrical deserts that impact both maternal health and infant mortality. For this heat map, orange is an absolute desert. Yellow is relative, and then the darker the color gets, the better the access to perinatal care gets. So you can look at your districts and the counties that you represent, and you can see what the access to perinatal care, both prenatal and postpartum care, looks like for your areas. Now, for us, I will push back on how many people defined OB deserts. An OB desert is not a county without an obstetrician. An OB desert in public health is a county where it takes a pregnant mom more than 40 minutes to get to care. And that's what this heat map demonstrates. It is showing the drive times for pregnant women to get to access prenatal care, and not just a birthing hospital, but also remember our FQHC partners do a great job providing both prenatal and postpartum care. Can I get through? Okay. And so this is each one of your regions are there for you.
Dr. Edney, just one second. This is a legislative hearing, so legislators will be asking questions. If you do have questions of our presenters, you can catch them outside of the room. Thank you. Because this is a legislative hearing. Thank you. This is not a town hall. This is a legislative hearing that's being conducted by legislators.
Correct? So you're our boss. So we get to ask questions. That's why I was wondering why it is I have to wait outside for my boss to ask my boss, or not my boss, I'm their boss, actually, my employee. You're my employee. So why do I have to wait outside?
Excuse me, ma'am, excuse me. This is a legislative hearing being conducted by legislators. You can ask your questions, just not in this setting during this hearing. You can ask them to the side, to any of the presenters, or following the hearing. But we are not taking questions from the public or from guests during this time. Thank you.
And I will be happy to address any public questions for you. So you're going to hear a lot about the importance of maternal health, and I want to demonstrate how it connects directly to infant health and mortality. I also want to point out for you, here are potential solutions that we at the health department are working on. As I have been looking at this data the last 3 years, the approach that I have felt important for your Department of Health to take is, thankfully, we have so many partners throughout this space that are doing wonderful work. What is it that the health department needs to do? What is it that the health department really are the only ones who can do? And let us lean in those areas. And then when we have community partners who need to be leading, then support them and their leadership. And then many times we need to get out of the way and let other people do the work where they have more resources and more expertise than we do. So in that regard, number one, you've heard us talking about the obstetrical system of care. This will make this will be our state's fourth statewide system behind trauma, heart attack, stroke systems of care. We are dedicating an entire system of care for the state specifically for high-risk perinatal care. So high-risk women who are in labor, going through their delivery, and then taking care of their high-risk baby in the immediate neonatal period. We will be the only state in the country with a comprehensive system of care directed at perinatal care. It will catch us up in many of the national standards that Dr. Owen's committee has been recommending to everyone. This gets us to perinatal regionalization as soon as we can get a NICU back in the Delta and back in Southwest Mississippi. But the system of care is going to help birthing hospitals perform at a higher level than they ever have in the past. There's a higher level of accountability for the care given for our moms and babies, and also making sure we know what hospitals can do, what our nurseries can do, what our NICUs can do, where are they, what are their capacities and capabilities, and then facilitate moving our moms and babies to the right level of care, not just the closest, but the right level for the risks that they have. We are closing the OB deserts. We're looking at counties that truly do not have access to prenatal care and postpartum care in the community, and we're going to stand that care back up in the county health departments because they are there, and we're going to do that in collaboration with their OBs. We're going to make sure these moms are able to get into their OB quickly and that they have transportation to get to their OB. And then y'all, it's really important. Y'all passed 12 months postpartum, but too many people don't know it. And we've got to make sure our moms know they have Medicaid for a full year after they deliver, not just those 2 months, that they have access to health care for that full 12 months. And we've all got to do a better job communicating that. We're going to be leveraging community health workers through our Healthy Moms, Healthy Babies program now that y'all have approved CHWs. Thank you for doing that. And we're making a hard push in the accidental deaths of babies. That's our older babies, the babies that die more than a month old. Those are mostly accidents. Many of those are accidental strangulations and suffocations by co-sleeping in the bed with mom and dad or the grandparents. I want you to know that we just purchased 750 quality cribs that are going out to low-income families that don't have cribs so that safe sleep can be practiced. And so it's going out to all of our Healthy Moms, Healthy Baby families, going out through all the county health departments. And we have RFA going live next week with our partnering with community-based organizations to get the cribs out and teach about safe sleep. Always put the baby down on their back in a crib. Always on their back in a crib. Big statewide campaign for safe sleep and the grandparents campaign, not just directing at the parents, but folks like me to make sure we're protecting our grandbabies by getting our pertussis boosters done, so we protect infants from pertussis and help the grandparents understand about safe sleep and safe car seats. And 6 is really important. We're actively doing listening sessions with all of our highest impacted counties, with the elected officials, our mayor health councils, our community partner leadership, listening about what do the communities think is going on, driving that big spike that we've seen the last couple of years with African American infant mortality, and doing what we did during COVID, listening to the communities, asking what they need, how can we help us understand better and not pretend to know all the answers coming out of Jackson. And those listening sessions have been very instructive to our work and helping us know how we can be better partners at the health department with our communities. Here's just some recommended legislative action to consider. I know we're short on time. I just have these issues here for your consideration. One thing we're doing, we are pulling infant mortality review out of child death review and using the same model with reviewing the deaths of babies that we do with the deaths of mothers. And we are likely going to ask for specific authority in that area to do fetal infant mortality review the same way we do child death review and maternal mortality review. So we learn so much from those mortality reviews that I think, number one, will be very, very helpful to our work and giving you that information. I remind you, every December you get the maternal mortality review report and the infant mortality review report. That will be coming out to you very, very soon. Number two, public health funding for maternal infant health. Y'all have helped us in the past, and we're grateful. And I want to say thank you for what you've done for us in the past. But federal funding is becoming more challenging, and this work cannot stop because federal funding is being cut, and it will not stop. Item 3, health policy that promotes the health of women of childbearing age. We have two. Dr. Owens will speak more to this, but we have two. It is just unacceptable that women are accessing health care because they get pregnant. They're already high risk. We need to get upstream and help them be healthier before they get pregnant. And as has already been stated, we've got to help them recover from their pregnancy and remain healthy to prepare for the next pregnancy. Just having this short window of time when they're eligible for Medicaid is driving a lot of our poor outcomes with maternal health. Item 4 is really important for the health of the population, but it will help it's getting way upstream with maternal health. We've got to teach young people important issues related to health promotion. And so health and education are working to partner together with this. We would appreciate the support of the legislature as we do that, and that, for funding health promotion K through 12, but also funding school nurses. The health department can only fund about 54. We need a lot more than that. And lower income school districts need school nurses, which helps young women be healthier so they can be healthier moms when it's time for them to get pregnant. Number 5, incentivization works for workforce development. Part of our problem with maternal health is we don't have enough providers at all levels: CHWs, doulas, licensed certified nurse midwives, family medicine OB, and OB. We don't have enough at any level, And when you look at the core Mississippi Delta and Southwest Mississippi, horribly drastic workforce shortages in those counties. And please think outside the box on how the state can incentivize to get providers in those counties to take care of our moms and babies. Number 6, y'all, it's okay to incentivize women to do what the evidence shows will help them be healthier. The Medicare does it all the time. They incentivize flu shots and colonoscopies and everything else. It is okay to incentivize pregnant moms to engage in prenatal care early, to make all their appointments if they're high risk, to make their maternal fetal medicine high-risk appointments, incentivize them to do their postpartum care follow-up, incentivize them to stop smoking, incentivize them to help work on weight reduction and nutrition. Incentivization works. The evidence is very strong. Every time we try to do a little incentivization at the health department, we tend to get our hands slapped. But it makes a lot more sense to spend $25 on a Walmart gift card than it does to spend $1 million on a NICU admission. And number 7, facilitate collaboration among all of us, kind of make it the expectation. The health department's been one of the greatest offenders of being siloed in the past, and I just don't work that way, and we've been working at the health department to be better partners. I'm grateful for our FQHC partnerships. Mr. Shirley is here. Grateful for our community-based organization partnerships. There's a lot of work going on in this space, but from my perspective, there's not a whole lot of collaboration going on. So we need all of us pull together, and I'm committing that the health department wants to do that and will do that every chance that we can get. And whatever y'all think in terms of legislative action to facilitate that, incentivize that, or mandate that would be well received, and I think would be effective. So, Madam Chair, I apologize if I went over, but once I get going on this, it's hard to stop. Thank you.
Thank you, Dr. Egney, for your presentation. So which one of these helps with transportation issues? As I was studying this before I came in, I saw that was one of the big factors.
It is.
Making sure people have transportation. What are we doing about that?
So in this population, it should not be a factor because of Medicaid transport, but that has been a challenge as long as we've had Medicaid transport, of it being as effective as it needs to be. I know the division has a lot of frustration with the transportation program, but all of our Medicaid moms should have access to transportation to their doctor appointments through Medicaid transport. However, oftentimes those companies will cancel on them at the last minute, and what we're doing at the health department is we have been working to facilitate transportation through rideshare for any of our folks with any of our programs, including our Healthy Moms, Healthy Babies program. So if one of our healthy moms had an OB appointment and Medicaid transport couldn't accommodate it, then if we could arrange transportation, we have been. I know transportation is being looked at very hard through the Rural Health Transformation Grant, because it is the #1 challenge of accessing health care in rural areas consistently.
And finally, for my own, is there any state that is doing it right that we could copy and paste and kind of implement from a legislative perspective some of the things they're doing in that respective state?
Yes, sir. So what we're doing is looking at best practices of other states that are like us. So it's hard, I can't really use New York State as much of a model, but I can use Georgia. And I have been, I'm close with all the state health officers, especially in the Southeast and the Southwest. And we have been talking a lot about this the last 3 years, but there are things my colleague, Dr. Toomey in Georgia, has been doing well, that we're pivoting our Healthy Moms, Healthy Babies program to follow the evidence they're generating to try to improve our outcomes. Texas has done a good job in their frontier areas with their maternal levels and neonatal levels of care. And so we have been following their model as we build the OB system of care, which involves that. And then, you know, and one thing I would say, when you're worst, it's still okay to be first. And so there's nothing wrong with us leading the way with systems of care for high-risk moms and babies. And I will tell you, we're getting a lot of national attention as we are constructing this. One thing to understand with the public health emergency, the main reason for declaring it was to get state government out of the way as we were building systems to help these babies. So the health emergency allowed us to buy those cribs in a matter of weeks instead of months. It's moving up the timeline for the implementation of the OB system of care. We're on schedule to begin implementation in January instead of next July. And so, and in my opinion, every month that we're able to activate one of these critically important programs, if it saves one baby, it's worth the emergency.
No doubt.
So that's the purpose of the emergency. Yes, sir.
Thank you, Dr. Edney. Thank you, Chairman
Thank you.
Kareem. Representative Thompson has a question, the
sorry.
gentleman from Lee
Thank you, Dr.
County.
Edney.
Yes.
I have a question for you. When you was talking about the vaccines and everything, what is the vaccine rate for African Americans when it comes to the maternal health? Is it up or down, or how is that now?
Very good. Our childhood vaccination rate for the state is about 97.5% fully vaccinated. The African American community tends to have a robust vaccination rate. And I would remind y'all, the one health disparity that we have eliminated was with COVID mortality. And that came about by working with the communities to improve vaccination rate uptake in our minority communities. And African American population went from the highest mortality at the beginning of the pandemic to one of the lower mortalities and significantly lower than the white mortality from COVID. That was because of us working with the African American community to vaccinate in a way that made sense to the community, and it eliminated health disparity. So tell me another episode where we flipped mortality rates, where Caucasian mortality is higher than African American mortality. And that's why I want to follow that model of working with the community, listening to the community, and we're going to need to do it differently in the Delta than we do it on the Gulf Coast, and that's okay. You know, we need to listen. So the vaccination rates in the African American community remain strong.
Okay. My next question is with the health departments. We're looking at different hours in transportation, and we know that health departments are not in every community now. How are you planning to address that to make sure that we have good hours in transportation when it comes to maternal health, since we're in this type of situation dealing with a crisis with maternal health?
Yes, sir. So we are putting more investment in our level 3 clinics, which are strategically placed and are growing so that they are open 5 days a week, fully staffed with a provider there every day. And then working to improve rideshare access, you know, to get our folks to those clinics. We are just looking at where the needs are. I will just have to tell you, I have some counties, you know, I can't afford to invest $300,000 a year to keep a building open that is seeing 2 people a week, but I can pay to take them to one county over where I can stay open 5 days a week. So we're just looking at the best way to spend the taxpayers' resources and yet still provide even better public health coverage. You know, what we were doing 5-10 years ago, people didn't know when we were open, where we were going to be open, and so we may not have a county footprint everywhere, but we will have a public health footprint everywhere. And if you think about it, county-based anything's not working real well. But what I care about is, that Issaquena County is well-served just as Sharkey County is, and that we do what's needed, that the folks in Issaquena County have access to core public health care. And if that means that we have to pay to get them to Vicksburg or, or Rolling Fork or Greenville, then we'll do it.
And my last final question, since you said that, since some will not be open, how will you do with the PSA to make an announcement? You know, rural communities sometimes don't get the message that they're open at certain hours and stuff like that. As a health department, what will you do to engage the community to make sure that they understand if you can't get here, we'll provide transportation?
Yes, sir. So what I have been really instructing our field service folks to do is, we can do social media messaging with geofencing for Franklin County alone, and we can, talk to the people in Franklin County about here's our operational hours, here are the services available, here's what's available in Franklin County, here's what's available in Jefferson County, here's what's available in Claiborne County, and do more local communication, which 5 years ago just wasn't being done at all. And we're, in state government, everything is a work in progress, I find, and we are working towards improving communications between the county health department and the community they serve. And my folks hear me preach all the time, it is your job to be relevant to your community. If people aren't coming to the county health department, then they don't value what we're doing. So you must communicate with the community, you must be a part of the community, and that's why community health workers are important to us. They are in the community doing exactly what you need us to do.
Okay.
Lady
got
from
one
John,
last final
I'm
question.
sorry, go ahead.
I have one final question. We talk about Medicaid and you talk about the poor maternal health. How would that really deal with what you do to get more maternal health? Since we're dealing with Medicaid, we know the changes are coming. How would that affect your part?
Well, the fact that we're a non-expansion state means that we're not going to be, that our Medicaid funds are not going to be hit as severely as the expansion state. So we're not anticipating a significant reduction from the BBB in terms of Medicaid enrollees, and we need to improve enrollment. We need to get more lives covered on Medicaid. It is going to reduce funding to the hospitals, but it's going to depend on how much funding y'all provide the Medicaid program this coming year from the state level. Will determine really what we have available to us. I think there's a need for another $300 million for the Medicaid program. In my opinion, that's money well spent. We will never get off the bottom in health if we don't invest in covering lives every way that we can. But what we are seeing is even in our moms who are Medicaid eligible, even our moms who are Medicaid active, we have too many who are not engaging in prenatal care early. And that's the question we're asking the communities, is help us understand, because if you look at the maps I showed you, you can see the counties that have birthing hospitals. You can look at Washington County and Bolivar County and Coahoma County, all have birthing hospitals with OBs, and look at the mortality rate for those three counties. And those are Coahoma County babies dying, not babies dying in that hospital. They're from Coahoma County. And we look at the history of their moms, and they're showing up late for the prenatal care, and they're high risk. So we've got to see.
Your legislative action item number 2.
Yes.
Can you give us some idea of what you think your request would be, your escalated request for public health funding for this issue?
For this year, we're still going to be okay. I'm more concerned about next year. And
okay, now are you talking about our funding? You're saying in the operating year now. I'm talking about when we come in, what is your ask for number 2 going?
Yes, ma'am. Mm-hmm. For the 2026 legislative session, it's going to be, unless something changes when we hear from the feds, we have generated more revenue and improved our fee structures with y'all's help, that we have enough resources to do the work we need to do without asking for more money. So we'll be having a level funding request for the 2026 session. The 27 session is where I'm concerned that we will have had significant cuts that we won't be able to overcome ourselves.
Okay, so I can understand. You have number 2, public health funding for maternal infant health issues. Within your request that you're making this time, there is no escalation, so you have, this shouldn't be on here, because you already have money.
It's on there because y'all have already increased.
Okay.
And I'm very grateful for that, and I'm just begging it not to be cut.
Okay. Now, the other thing I wanted to ask you, in your solutions, I don't see anything on here for fathers and husbands, and I'm not being critical.
Yes, ma'am.
But what I would ask of the health department is that if your people could create something that would involve husbands and fathers,
yes,
I think that might would help
absolutely
that situation. And then on your legislative action number 5, when you spoke about doulas and midwifery, has the health department's the board taken a position on doulas and midwifery?
We're in full support of CHWs, doulas, and appropriately trained midwives.
And so that is your testimony?
Yes, ma'am.
That you all believe there is a place for doulas and midwifery, and that this would help as it relates to maternal health.
Absolutely.
And
evidence is clear.
Okay. And then my last, on number 7, where we talked about the collaboration with the FQHCs.
Yes, ma'am.
As you know, Dr. Ebney, we have been trying to get the amounts of monies escalated, the state's commitment to FQHCs. I'm not going to put you on the spot because I know you have to advocate for money for your agency. But I do think that it is important that the leaders understand that you're saying that this is a critical collaboration with the FQHCs. And then if the state would make an investment, more of a monetary investment, that would help you, particularly in these areas where they got about 50 main and satellite offices, that this could help us, particularly in this area of infant mortality
Absolutely.
And maternal mortality. But that would be your testimony, right?
It would, and it's okay to put me on the spot because I'm always on the spot.
Well, okay.
But so I will say publicly, that our FQHC partners are not important. They're vitally necessary. If it were not for your public health network of clinics that are providing core public health care, and our FQHC clinics throughout the state and the free clinics, that is your safety net. And I would say, and I will defer to Mr. Shirley, but I think we're all working better together today than certainly in recent history. In fact, we have a summit coming up on infant mortality with me meeting with the CEOs of the FQHCs for us to look at the data together and talk about what can our FQHCs do to help us more robustly to get these numbers down, because they are a huge part of the solution. And now I will say that it's okay as we provide funding to hold all of us accountable. And if you, like y'all provided an extra $3 million for public health programming for us, that's where OB system of care is coming from. That's where closing the OB care gaps is coming from. And that's the only way Healthy Moms works, is with that money that y'all gave us 2 years ago. And I'm grateful. And you hold us accountable for that. It's okay to hold our partners accountable. Here's another X number of dollars, and we expect to see this in return. I think that's good government.
Thank you.
Thank you.
Okay. Thank you so much, Lady from Jones. Thank you, Dr. Edney.
Thank you.
I do have some questions, but we're running out of time.
I understand.
So
Thank you.
I will talk with you afterwards.
I know you will.
Okay. We appreciate the presentation. Next, we're going to have Dr. Michelle Owens. She is a maternal fetal medicine specialist, currently the National Secretary for the American College of Obstetricians and Gynecologists, the president of the Mississippi State Board of Medical Licensure, and the clinical director at MAE Health. She also serves as the chair of the Mississippi Maternal Mortality Review Committee, which reviews all the maternal deaths in the state to better understand the maternal health crisis. Dr. Owens has been practicing as an OBGYN in Mississippi since 2004. Do you have her presentation? Owens. And we'll pull that up, but thank you, Dr. Owens, for being here.
Awesome, thank you so much. So I'm really glad that Dr. Edney had the opportunity to address this group in advance to kind of lay some of the groundwork of the work that we've been doing collaboratively. And I will start out just with a thank you, because the Maternal Mortality Review Committee, while it is heavy work, as Dr. Edney mentioned before, it is also, in its own way, very gratifying, because oftentimes we are an opportunity for hope for these families who have experienced unimaginable losses. And we finally get a chance to see things in a way that sometimes providers and families don't get a chance to see things, so that we can suggest and make recommendations that are very broad and not limited to just one particular aspect of healthcare, but that actually can be life-saving and life-changing for the people who are left. And so I think one of the things that we often in our committee talk about is the issue of the legacy. And when that legacy is loss, how do you take that and make something positive come from it? And because we do have the ability through informant interviews to reach out to family and friends of those people who are affected, I think it does give them hope and gives them some measure of peace that the loss of their loved ones was not in vain. And by no means is it bringing back or replacing what was lost, but it is, I think, a step in the right direction. And for anybody who has walked that road to know that their loved one has been a contributing factor to minimizing that for some other people oftentimes gives them peace. Good morning, everyone. As you heard, I'm Michelle Owens. I am a maternal fetal medicine subspecialist, which means that I'm an OBGYN by training, but I practice high-risk obstetrics. I'm not a native Mississippian. I say I'm a Mississippian by choice because Mississippi has become my home. It is a place that has given so much to me because I grew and developed into the person that I am largely because of my experiences here in this state. The experiences with wonderful mentors and colleagues, and also with incredible patients, and also a very adamant grandmother who told me when I was considering leaving, she was like, you can't leave that place because there's so much good work to be done there. And coming from a lady who grew up in Alabama, that's actually a big thing. So I'm grateful just to be able to be here with you. And gratitude is going to be one of the themes that you will hear throughout the course of this, because I think that's one of the things that helps to center us as we're trying to do this difficult work. And so I said gratitude, and then I show you the picture of the three little people. This is going to be an informative, hopefully, discussion about some of the data with respect to maternal health in Mississippi. But I will also first share with you that first and foremost, while I'm a maternal fetal medicine subspecialist, I am a mother of 3 children. I am a Mississippi mama. I birthed my children here. Mississippi has given me a lot. It's given me my family. And after those 2 little adorable things in the front tried to take me out, and I say that in jest, but again, with reflection and gratitude, because I am a survivor of a severe maternal morbidity. And I recognize that despite my education, And despite my status and my position, I was laying on a bed and looked at my doctor and said, I work here, don't let me die here. Because of that, this work for me is not just business, it's personal. And I recognize that I am sitting here in front of you today because of privilege. The privilege of my position. I was able to open up my phone and make phone calls to assemble a team that could help to save my life in a time of critical need. I recognize that I've also taken care of many women, some of whom are not here. And the only difference between me and them is that I had those numbers in my phone. I had the contacts. I had the knowledge. I could recognize when a nurse said to me, well, your blood pressure looks fine. I said, well, look at my pulse, because I should be about in stage 2 shock right now. And she was like, oh, it's very high. And I said, yeah, because I know how much blood I've lost, and this is probably what we should do. There are a lot of women who can't advocate for themselves in that way or don't have those contacts, and many of them are not here for those very reasons. So I say that again with gratitude, because it's really a gift, and I'm a person who's a recipient, the gift of these children and also the gift of my life. And being in the right place, when Dr. Edney talks about that coordination of care and every mother being in the right place at the right time, I didn't have to drive 2 hours. My husband didn't have to pack me up in a car and drive me to a place, and they say, well, we don't do that here. You need to go somewhere else. I wasn't on an ambulance just riding to the nearest facility that might have only had 4 units of blood in their blood bank. I went to a place where as many units as I needed, they could give me. And they would keep sending them until the doctor said, don't send anymore. So again, it was privilege that I sit before you today. And so I don't take this lightly at all. And I believe that I was spared for a reason, and my reason is to help fight to make sure that there are far more women who are like me, who are here, because they were at the right place at the right time and had access to the right care in a timely manner. So really quickly, I just want to level set, because I don't want to presume that everybody knows exactly what we're talking about. Dr. Edney mentioned his public health definition of maternity care deserts. When you hear me say maternity care deserts, I mean the places where there's not nobody there to do it. So you will not find an obstetrician or a women's health care provider in that area, is what I mean when I say that, just so that we all make sure that we're talking about the same thing. We use the term preterm births. A full-term pregnancy is 40 weeks, right? So that due date represents a 40-week gestation. We call term births occurring from 37 weeks all the way through. Full term is, of course, 39 weeks and beyond. Preterm is prior to 37 weeks, so 37 and 6 weeks and before. When we use the term low birth weight babies are considered, if you are less than 5 pounds, 8 ounces at term or at 37 weeks, you are considered low birth weight. The extremely low birth weights are those that are less than about 5.5 pounds as well. And then, of course, we know about social determinants of health, how people work, live, and play, and all of those other contributing factors that make them who they are. So I believe, fundamentally, I told you a little bit about my background and some of the things that brought me here, but this is also a fundamental thing for me. I do believe that you shouldn't have to choose between living and your health. I believe that you should be able to live healthy. You should have both. And I think it is a reality that needs to be stated, that for many people in the state of Mississippi, they have to choose between living and their health. They have to decide whether they're going to put food on the table or if they're going to purchase medications. And I think we should be thinking about, how do we help people to be able to live healthy? So really quickly, just to give you kind of an idea, an overview, 30,000-foot view of where we are, and this is maternal and infant. Maternal fetal medicine person, you get both of them in me. So when we think about Mississippi at a glance, first of all, 1 in 7 babies are born preterm. 15% in the United States, the national average is somewhere around 10%, roughly 500,000 babies per year nationwide. 1 in 8, which is 12.5%, are in that low birth weight category. You've heard Dr. Edney talk about the infant mortality rate, roughly about 9.1 or so per thousand. Our C-section rate, which also can drive morbidity and can also kind of relate to some of the complications that are that women may experience in pregnancy, is higher than normal at 37.9%. But I will say that this is the aggregate number. There are some facilities in our state where that number is actually 50%. And then roughly 1 in 6, or 17%, just under 20, of women that are of childbearing age are uninsured. And I'm happy to make this available to you all, these slides, so that you don't have to scribble furiously. I will make them available to you. And this information is just kind of, it's all available publicly, but I've consolidated it. So I just want you to know what a week in Mississippi looks like. In an average week, 666 babies are born. Roughly 98 of those are preterm. And 84 of those are low birth weight. And 532 women, needed adequate prenatal care. So that's kind of a week in the life of the OBGYN pediatric folks. So really quickly, I kind of alluded to this before when we talked about our preterm birth rate. Our rate is 15%. It's higher than the national average of 10.4. For another year, we've received an F by the March of Dimes report card. This is 2024. The 2025 report card has not been released yet, but should be coming soon. But this just also lets you know, it shows here our health disparities that exist with African American babies being 1.4 times more likely to be born preterm compared with other babies. And I just show you this. The red areas are the areas that kind of have the lowest scores. They might have a little something in common. They're all kind of nestled together. But this shows you kind of where we are, where we rank, and also who's kind of in the sandbox with us, right? This again just shows healthcare disparities as it relates to preterm birth rates, with African American children being born premature at higher rates than our other racial and ethnic counterparts. And I will also say, as Dr. Edney alluded to, we really need to work together on this. This preterm birth rate is also a significant driver of his infant mortality rate, because those babies who are born too soon, it's kind of like taking a cake out of the oven. They might look like it's right, but if you pull it out too early, you're gonna know it's not done on the inside. And then what happens is you end up having difficulty or issues with that baby being able to be healthy because it was born too soon. So these preterm babies are the ones that are really the drivers of a lot of our infant mortality. So really quickly, the MMRC, you all already know what we do and how we function. We've been in existence since 2017. But I just wanted you to know what our job is. Besides just reviewing these deaths, we are multidisciplinary, and we are an independent team, which is great because we get a chance to talk about all kinds of things. But we are charged with determining cause of death, pregnancy, whether it's pregnancy related or not. We talk about preventability and also the likelihood or the ability to make a difference. Like, how big of a difference do we think we could make if this change had actually occurred? And then other contributing factors, and we make recommendations. And then we report that data not only to our state with our annual report, but it's also reported to the CDC where that information is aggregated. So when you hear national data reported from the CDC regarding maternal mortality, you can know that the lives who've been lost in Mississippi are part of that chorus. They are, that information, that data is being memorialized and contributing to the national data. So where we are specifically with maternal mortality. So this data is not the new data. We will have a report that's coming in in a few weeks, but this is the data that's already in the current report. that lists our maternal mortality ratio, 39.1 per 100,000 births. Mississippi doesn't have 100,000 births per year, so just be aware when you see these ratios. We typically max out somewhere between that 40 to 50,000 births a year. We don't ever have 100,000 births typically, but that's our ratio. The non-Hispanic Black rate is still significantly higher, 4 times higher. It's been consistently 3 to 4 times higher than that of non-Hispanic whites. The vast majority of deaths will occur during pregnancy or within the first 60 days after birth, so it's still an important time, but that leaves another 42% that occur after that 60 days postpartum, and this is the time when I think we should really elevate the importance of being able to provide consistent care to people so that they don't just kind of fall off of their care curve immediately after giving birth, but that they still have support during that time that their bodies are trying to transition back to the non-pregnant state. Again, over 80% of these deaths were determined to be preventable by the committee. And that is in line with what we see nationally. The national number is about 80%. This is just a graphic demonstration of the same, again, illustrating that there are health disparities that exist among racial and ethnic groups. And so these are the top 4 leading causes from our prior report. And these are medical causes. And so I want to take a moment, though, to say that what we are seeing is a rise in some other contributors to maternal mortality. One of which that I would like to elevate here today is mental health. It is rapidly surpassing as we are starting to become more consistent in how we are treating people who come in with medical complications. We're starting to see where the gaps in mental health care are starting to show in outcomes. And so as we are working to fix the medical components, what we're seeing now is that the gaps that exist medically for those people who have mental health issues are now starting to be more visible and more prominent. So we're seeing mental health issues as increasing contributors to maternal mortality, as well as substance use disorder. And I will also say, as a maternal fetal medicine specialist, that there are opportunities for treatment for women who have substance use disorder in pregnancy. And they can be successfully treated, especially in the absence of criminalization. They can be supported, effectively treated, and have healthy pregnancies and healthy outcomes. So that is something that is within our reach. It is something that we can do. If somebody tells you that it cannot be done, they are not being honest and transparent. Because it can be done, it has been done, it's being done in other places. We can do it too. There's like a little book I used to read to my kids that said, you can do it too. We can do it too. And this just demonstrates the timing of death that we've seen with these mental health challenges. The other thing that I also want to mention that often doesn't get a lot of information or playtime is the contributions of homicide. And I will talk about this gun violence issue because it is becoming increasingly more prevalent in our reviews. Now, homicide during pregnancy or within 2 months postpartum actually outpaces medical complications or medical causes of maternal mortality by like 2-fold nationally. That's not Mississippi data, that is across the board. So again, I appreciate Representative Summers when she said, making sure that we are thinking about all of the areas that touch the lives of these mothers. One of the biggest mistakes I think we can make is to treat people medically as though they are a diagnosis and not as a person. And I feel like when you recognize the environments that these people are in, the social determinants of health, and how we're really working to not only make people healthy, but also to help them be safe, it's really important. And so I wanted to share that information with you as well, because intimate partner violence, and this has been Domestic Violence Awareness Month, we are not going to solve the maternal mortality crisis without addressing issues of intimate partner violence. So these are some key factors that affect healthcare access. And this, you can kind of figure out what color you are, or what place in the wheel really resonates for you. I think there's something for everyone here. It talks about the social drivers of health, as well as healthcare services and delivery, all of those things. We, in our committees, review maternal vulnerability. So we look at what social factors help to create more vulnerability within our within the people whose lives we're reviewing and within our communities. And so it's a composite that is made up, and this is just a schematic showing the vulnerability index by county. And again, when we are looking at this, or we're utilizing the vulnerability index, we actually have the benefit of being able to see all of the different indicators and where they fell on the graph. But this is just an overall to show you some of the other tools that we are utilizing as we do our reviews. So we're talking about healthcare access, and access, of course, is more than just proximity to. It's about affordability, it's about a lot of other things. But, and again, clarifying, for me, as I'm using the term healthcare desert here, it is the place where there are no people to provide the care. 51.2% of counties, and I put the national averages in the parentheses beside. So national average is around 32%. So we are almost twice that, closer to twice that than closer to. Roughly 25% of women have no birthing hospital within 30 minutes, whereas the national average is just around 10%. But it's still a significant amount of births. Now look at this. Almost 25% of all births occurred in these maternity care deserts. Well, who's delivering those babies? And 35% of babies born to women who live in rural counties. As a girl who grew up in who was born in a bustling city and whose parents decided to move to a rural area, that rural community means a lot. And I think a lot of times, that representation is really important because people need to have a lens of not always having everything at their beck and call or being in close proximity to a lot of different things. I think when you are in a larger area, sometimes you forget that some people can't just reach out and touch something. So going on and staying here, 25% of maternity care providers practice in rural counties. 25%. So that means that the other 75% are packed together in non-rural areas. And some people say, well, that, kind of makes sense. More people need more people, right? But I would just say that these people probably need more people too. This is just a schematic that shows on average how far people have to travel. I'm sorry, I thought I had another one on there, but and women living in maternity care deserts usually travel 3.2 times farther than those who have full access. So it's a substantive difference. And this, again, is just another diagram that kind of shows the deep purple are the people who go the farthest, and the blue are the people who have the least distance to seek care. The places that are white or gray are places where the data or information was not reported. But I just wanted to share with you kind of what we look like, not only where we are immediately, but what we look like in compared to other places that are reporting this data. So somebody made mention of this before. I think it was the international president of Zeta Phi Beta Sorority Incorporated. But my good friend Joya Career Perry said this, and I use this often in my talks. What would it look like for mothers to not only survive pregnancy, but to thrive? Survival should be the floor. It should not be the ceiling. And right now, what we are doing is we are still struggling to find a way for people to survive. While that is good, I would submit to you that that should not be, when we get there, that's not when we pat ourselves on the back. Because what we really need is we need Mississippi to thrive. If we are going to continue to grow and be who we are meant to be, if we are going to live out the true legacy of this state, then we need our people to thrive. And so please don't stop with survival. I'm happy when our survival numbers go up. I think that's great, but please let's not stop there. Continue to dream and to push and to require the absolute best, because our people deserve it. Dr. Edney gave a solution slide. These are some of the things that I think we really need to kind of work on. And for me, it's about supporting Mississippi mothers. Dr. Owens, how do we do it? Well, first of all, we increase access. What does that mean? I mean access in all of its lovely forms. Where people are getting care, we need to have appropriate and adequate locations for people to get the care that they need. We need to supplement our workforce. We need to increase our workforce. We're not enough. It's not enough of us. And the other thing is, we need a workforce that is capable of caring for all people. We also need to have people who are reflected in the communities that they serve, and so that those communities can see those individuals. So I believe, and business literature has supported this, I believe that a diverse workforce is a strong workforce. And I think that there's a lot of literature to back me up. We're talking about being evidence-based. And it needs to be affordable, because you can be right next door to the clinic, but if you can't afford to get there, guess how often you're going? And what's gonna happen, you'll wait until something gets really bad, and then where do you go in the ER? And we know that that drives costs up. Doula incorporation is also really important, and I say doula, but really it's about support people for folks while they're birthing is really important. And this, again, is evidence-based. So there is data to support that having a person at the bedside consistently improves pregnancy outcomes, decreases C-section rates. So what does that mean, Dr. Owens? Well, what that does is it basically suggests that what we do with our hearts can even be more powerful than what we can accomplish with our hands. Because having somebody as a support person at a bedside for a birthing person makes a difference in their outcomes. Case management and social work support, again, treating the whole person, making sure that we are addressing all of their needs. Because if I got diabetes, it's not just about my blood sugars. It's about so many other things. It's about my nutrition. We talking about maternity deserts. Do I live in a food desert? How am I supposed to eat like I'm supposed to eat? Especially if I'm on a fixed income. Those kinds of challenges are the day-to-day challenges that patients have to make in order just to be able to survive. And I will just close by saying pregnancy should not be a death sentence. It is supposed to be a time of great joy, and typically people see it as a time of like optimism and like so much positivity and this new life that is coming. And whatever kind of world you're bringing them into, most people are thrilled about that. But now more and more I'm seeing women who come into my office and they are also not only worried about the life that they're carrying, but they're worried about fighting for their own. And what does that look like? Is somebody gonna hear me? Are they gonna see me? Am I gonna be dismissed? Am I gonna die? That's relatively new. And I'm hoping that together we will find a way to bring the joy back into pregnancy and birthing again. I think love is a part of it, because love casts out fear, because fear has a real wicked way of coming in and stealing all the joy. But I'm really fighting to help women be able to retain that joy and to get their joy back. And I hope that you all will join me in that. So again, thank you all for your time, your attention, and for the work that everybody is doing in this room. We have been so much more coordinated and so much more collaborative over the past few years than I've ever seen in this state with respect to making things better for mamas and babies. And I think that that bodes well for them and for our future. But I just want to say thank you to the Legislative Caucus. Thank you to each and every community person represented, all of my medical colleagues, And just some of you who are just some of my regular old friends and scoundrels, thank y'all so much for everything that you're doing. We're making a difference. We're moving the needle. We got a lot of work to do, but we got a corner of our dirty room that's already cleaned up, and we just got to keep cleaning. So thanks.
Thank you so much, Dr. Owens. And thank you for taking care of me in my last pregnancy as well. And I'm glad that you mentioned doulas and the importance of nutrition. We are honored to have a doula here that will be giving testimony later, as well as the state WIC director. So we'll talk more about that. I have a question in regards to one of the data points that you point out for C-sections. You said that Mississippi has about a 38% cesarean section rate. I have heard from mothers who have felt like they have been pushed into having a C-section versus a natural delivery. Can you speak to what's contributing to the high rate that we have in Mississippi?
Yeah, so first I think a portion of that is the overall risk profile of our patient population, okay? So I will say that there is a large high-risk population, and I think that that drives to some degree, that's part of the answer. It's not the entire answer. And again, I think that goes back to issues that can be related somewhat to workforce, because in many instances, you may not have a lot of providers who either can perform that service, and if you are in a place where, like say for example, if there's one physician who can perform C-sections, well, that person generally can't just do C-sections at any random time and still be able to live their lives, just realistically. So I think the concept of scheduling is one of them. I think that risk drives it too. And when I say risk, I don't mean the risk of the individual, but for example, if you've had a prior C-section, there are some facilities that will say, well, if you've had a prior C-section, then you have to have another C-section. They won't allow you to have a vaginal birth after. Now, there are some instances where people should not, but in some instances it may be facility driven, right? Because the facility will say, oh, those are riskier deliveries, and if they don't have the appropriate staffing or the ability to provide a vaginal birth after a person who's had a C-section safely, then they'll just say, we just don't do that. And I will definitely say I don't think it's wrong for someone, if they don't feel like they can safely provide a service, to just say, we're not going to provide that. That is not a wrong thing. So I think that there are lots of different things that kind of come together to create that higher C-section rate. But as far as individual experiences, what I will tell you is we probably have a lot that we could do to communicate better with patients, or even what those conversations look like. How are we really talking to patients about their delivery plan? Do we discuss planning for delivery and birthing before we actually are in a situation? And so I think that there's probably also opportunities that exist as we are leading up to birth to kind of talk about what patients really want, what their desires are for birth, and when those plans and desires are reasonable, or when they may need to be changed or shifted. But I will say that when it comes to people sharing their personal experiences, I believe them, because you can't tell somebody what they went through. But there may be a lot of other factors that we don't, as healthcare professionals, usually share with people that might help to give a little bit more clarity, or at least peace, to the individuals who feel pushed in one way or the other. But I mean, there are always opportunities for you to pursue other opinions if a person tells you something that you don't feel comfortable with.
Thank you. Any questions from the members? Lady from Jones.
Thank you so much, Doctor. I wanted to ask you, I saw that you all had some executive recommendations to us. But I wanted to ask you a question about how you have so many young people dying, mothers dying, and what do you, the health department is saying to us that in item 4 that we need to support MDE with a more comprehensive health promotion from K through 12. My question to you is, we know that there are a lot of deficits that contribute to mothers dying, but in particular young mothers. So what would a comprehensive health promotion, or what legislative action would you recommend? I'm not going to ask you, I guess, to speak on it now, but if you could, that would help us so that we would know kind of what that would look like, that we would request of MDE, since we know we have these young, extreme, 44%, I believe, of young, they're less than 19 years old, dying, if you could.
Absolutely. I'd be happy to weigh in on that.
And then the other thing I wanted to ask you in your recommendations that you all had for, I think it was in your, may have been in 2021, I want to be clear about it. You wanted us to, you talked about education on preeclampsia, blood pressure monitoring, that kind of thing. Now, we passed and put in money for community health workers. We're in a collaboration with federally qualified health centers and rural clinics and what have you. We also have the whole telemedicine program. Have you all thought about how all of these entities could collaborate just to do these basic things, taking blood pressures, having some information about nutrition, you know, these basic things that could help?
So yes, we have, and I think one of the things that we spend quite a bit of time talking about in our committee meetings are how we can kind of help to pull things together. But there are some, I can give you some examples of where that's already happening. Like there are situations where we have like remote blood pressure monitoring, and then telehealth is being increasingly more incorporated into providing maternal care and for monitoring for people who have chronic illnesses. We can also do that for diabetes and those kinds of things. So there are definitely models. There are some states that have done this in a wider group of individuals and have done it a little bit more elegantly because they're a little bit further along from an infrastructure standpoint. But I believe that what we're doing right now has done a great job of at least laying the groundwork for there to be increasingly more collaboration. When the committee has made those recommendations, we haven't gotten as granular as to say this group, and this group needs to collaborate. We try to keep it broad so that as stakeholders and other interested parties see their work reflected in our recommendations, that they can try to organically create those collaborative groups. Much more so than us trying to, even though we're a multidisciplinary group, with our limited views, to be able to try to be very prescriptive on how and when people do. Now, we will give examples, but we haven't really tried to be very prescriptive because we didn't want that to be viewed as the only way to solve the problem. We wanted to say, this is the problem and these are how these things can come together, and then allow the individual parties to come together in a more organic fashion, because the truth is that we also don't know all of the organizations that are out there that are doing the work.
Well, I guess, let me, as a legislator, as a state representative, and looking at these horrible numbers of people dying, I guess my question is that, you know, anybody ought to be able to take a blood pressure and monitor it. You know, if the people are going to the health department or going to the doctor, if we've got community health workers, if we've got telehealth, if we've got all of these things, blood pressure and pulse are basic things, I think, that could be taken, and then from there, we could move forward. And in that, we're in crisis, and I'm not being critical, but in that because it's our, whatever it is, it stops with us, you know. But since we're in crisis, we're depending on y'all to give us an honest assessment of what we ought to be doing. And then, you know, and if we don't do it, then the buck stops with us. And clearly the buck stops with us when we got all of these mothers and babies dying. And so that's why I was asking you to think on, and that's why I asked Dr. Ebony about fathers and husbands, for you all to think on some things that you could come back to us and that we can advance. Thank you, Doctor, for your testimony and for your commitment.
Thank you. And I'll also say, just if you happen to keep or archive our former recommendations, pay particular attention to those things that are recapitulated, because if they are recapitulated in our recommendations, it is because the committee has continued to see adverse outcomes associated with that particular thing, and it has not yet adequately been addressed. So that's another, I think, maybe another helpful clue to help you identify some of the things that we are still struggling with or we continue to struggle with.
Thank you. A gentleman from Lee.
Thank you, Chairman. I just have one question this morning. As we talked about mental health and everything else, and what was in my mind, have you guys really looked at when it comes to drug addiction and everything, when it comes to the baby and the mom? Have you really done a lot of investigation of what can we do to really get involved in that part of the aspect of maternal health?
Well, yeah, one of the, so we do have mental health professionals represented on our committee, as well as social work and other people who have mental health backgrounds. One of the things that we have identified is that while there are resources available, those resources are not consistently known. We have also recognized that they are very few in number as it pertains to the unique circumstances of pregnancy. And so many of the facilities that would ordinarily be considered resources for a woman goes away if she's pregnant. And so there are very few places that will allow for short or long-term stabilization through the duration of pregnancy, and then to also include continued support after the birth of the child. So if we're going to talk about things that could be helpful, we have huge mental health needs in general, but if we wanted to specifically hone in on those that are unique to pregnancy, if there was a way that there could be, even if we could just build it into the infrastructure that already exists, where we had resources available for individuals to be able to not to be cut out of what's available because they're pregnant, but to be able to accommodate that person who happens to be pregnant, that could be transformative. You don't have to build a special center, but if you could just have a place where those people could be accommodated, that would be a huge, huge help in moving the needle for those patients who have issues with mental health and who are also pregnant.
What about drug addiction?
The same. I actually, in my mind, I put them all kind of under the same umbrella, but with substance use disorders, very much the same. In certain types of substance use disorders, there's actually medication therapy that can be utilized to help minimize the risk of people relapsing or using street or illicit drugs, especially with opiates. But there is definitely treatment that's available, even whether it's behavioral therapy or otherwise, that's available for individuals who have substance use disorder who choose to enter recovery, whether it's during the time of pregnancy or immediately after.
Thank you.
Yeah.
Thank you so much, Dr. Owens, for your testimony today.
Thank you.
We do have 2 more speakers for this section of the program, but we need to take a break. So let's take a 5-minute break, and then we'll come back with Dr. Catchings and Dr. Tucker. need to get back started, everybody.
Before we get started, let's get some housekeeping rules together. This hearing is for legislators to ask questions to the panelists, for you all to be informed. We're going to ask, if you're not a legislator, please sit in the black chairs or find some other seating. These seatings are just for legislators around this table. And we're going to be more respectful of time, please. We've got a lot to cover and a lot of information to get out. So I just want to make those few housekeeping rules as we proceed. I'm going to turn it back over to our chair of this committee, Representative Summers.
Thank you, Chairman Kareem. We now have Dr. Keisha Bell Catchings and Dr. Marty Tucker from the Department of Obstetrics, why can't I? Obstetrics, why can't I pronounce that word? And Gynecology at the University of Mississippi Medical Center. Thank you.
Good morning, and Mr. Chairman, Representative Summers, thank you very much for the opportunity to speak with you this morning. It's certainly a privilege to be here. As mentioned, my name is Marty Tucker, and I'm chair of the Department of Obstetrics and Gynecology at UMMC. I thought I would take 2 or 3 minutes to tell you a little bit about our department because it's so critical to the care of our moms in Mississippi, especially to our high-risk moms, many of which who end up at UMMC for care and delivery. Currently, we have about 20 full-time faculty members in our department. This includes our physicians, our nurse midwives, and our researchers. We work mainly out of the Weiser Hospital there on the campus of UMMC here in Jackson. We deliver about 2,600 babies per year. Most of those babies come from the Tri-County area, but we also see quite a few deliveries from central Mississippi and even from extreme north and south Mississippi, most of those on referral for complications related to pregnancy with the mom and or the baby. Our department also covers the full scope of care as it relates to gynecologic cancer, complex gynecologic care, and infertility care. A lot has been mentioned about workforce this morning. I thought it would be important to tell you a little bit about our educational efforts within our department. We are the only, or have the only, OBGYN residency program in the state. OBGYN residency is a 4-year program, and we train and graduate 6 residents per year. Fortunately, many, if not most of those graduates end up staying in Mississippi. We also have a maternal fetal medicine subspecialty fellowship program. Dr. Owens had mentioned that earlier. The fellowship program deals with the training of physicians, OBGYNs, who will eventually care for many of these high-risk moms that we have been talking about this morning, and we graduate 2 fellows per year from that program. In addition to that, all 160 of our medical students in each class rotate through the OBGYN rotation during their training during medical school. Our department has an active research team that emphasizes research in the areas of, related to hypertension in pregnancy. We talked a lot about moving the needle this morning. A lot of questions have been asked what can we do? How can we move the needle? And certainly as a department, we are focused on that every day. Not only how do we take care of this individual patient, but how can we make care better for all of the patients we serve and all of the patients that we consult on from around Mississippi. The first program that's been ongoing for about 4 to 5 years, I'm sure many of you have heard about this in other presentations, is our STORK program. The STORK program that we provide in conjunction with the Mississippi Center for Emergency Services over the last 4 to 5 years has gone out and trained first responders in the care of obstetrical and neonatal emergencies. And that team has trained about 1,000 first responders over the last 5 years, and I certainly think that it has moved the needle and made a difference in our emergent type care for our expectant moms. Secondly, we started a nurse midwife program at UMMC about 4 years ago. We continue to grow that clinical program. The goal there is to provide better access or increase access to prenatal care, especially for our low-risk moms. Thirdly, we have partnered with a company called Guideway. Guideway has done a lot of work in the cancer arena and has shown that cancer patients that have navigators that navigate them through the system. Dr. Owens, I think, told a very compelling story about how she was privileged and how she knew how to navigate the system. So our thought is if we can pilot that program amongst our high-risk moms and provide navigators for those patients in our high-risk OB clinics, that may be a game changer. It is, in full transparency, is a pilot program that over the next 2 years, we hope to follow 250 moms through that program to see if that will make a difference. And then lastly, something that I'm very, very, very proud of, because once again, it's been mentioned here this morning, is about the mental health issues that are pervasive amongst our obstetrical population. We've been very, very fortunate over the last 2 years to have a program within our OB high-risk clinics at UMC where we have these mental health and behavioral specialists that are actually embedded in our clinic. They are there every clinic with us, which has made a huge difference because, as been mentioned earlier, sometimes these mental health issues are kind of pushed to the back. We take care of the medical issues, take care of the obstetrical issues, and oh, by the way, we'll get these mental health issues, taken care of at another visit or whatever. We have the good fortune of being able to provide that at the time these patients come to our clinic. Before I introduce Dr. Bell, I would like to close with 2 thank yous to all of you and to the other members of the Mississippi Legislature. Both of these things have already been mentioned this morning, but I don't think we can mention them enough. First of all is the 12 months of Medicaid extension that has been provided for our moms who have delivered. That has been a game changer. That has been huge, and I can't thank the Mississippi Legislature enough for that. And then this has also been mentioned, but extending presumptive eligibility to our newly pregnant moms is also very, very important. So thank you for both of those. Those are huge when it comes to obstetrical care and the care of our moms and their babies. So it's my privilege at this time to introduce Dr. Keisha Bell Catchings. Dr. Bell is an all-star in our department. She is a Mississippian through and through. She is a Jackson native, a graduate of Murrah High School, and also Tougaloo College. She did a master's level training at UMMC before she went to medical school, graduated from our School of Medicine, did her residency with us at UMMC. After a short visit out west, she returned to UMMC and for 9 years served on our faculty as a general OBGYN and as a laborist. I mean, she walks the walk. She is the one who is and has been in the trenches for the last decade and a half. In July, she made a major career change in that she decided to go back and do a maternal fetal medicine fellowship, which she started in July. She will complete that training in July of 2028. We are counting on her to stay in Mississippi and, more importantly, stay at UMMC because that is such a great need. So it is just really a privilege to sit next to Dr. Bell this morning, and then she's going to take it from here and talk about every mother, every time, advancing maternal care in Mississippi. Dr. Bell.
Thank you. Good morning, and thank you to you all for allowing me the opportunity to speak today.
Turn your mic on, Dr. Catchings. It's at the top of the mic.
I'm little. Hold on. Oh, it says on. Let's go. Can you hear me now? You said it's a little better. Do you need it closer? Yeah. Okay. So I'll start over. Good morning, and thank you for the opportunity to speak here today. I'm here today as a clinician, a mother, and a lifelong Mississippian who has seen the human cost of the statistics we have discussed today. Our goal must be clear: every mother, every time. Safe, respectful, high-quality care should not depend on race, insurance, or zip code. It should be the standard across our state. This chart illustrates the gap between Mississippi and the rest of the nation. So you can see how our maternal mortality ratio has remained consistently higher year after year, even as national rates have plateaued. The majority of these deaths occur after delivery, as we have already discussed, in the postpartum period when mothers are home and vulnerable. That tells us something important. This isn't just about hospitals or delivery rooms. It's about how well our systems follow women through the entire perinatal continuum, from prenatal care through delivery, and especially in the weeks after birth. Behind these lines are real families. This data should not just inform our conversation, it should galvanize change. When we examine those data more closely, one pattern is undeniable. Black women in Mississippi are 4 times more likely to die from pregnancy-related causes than white women. That's not a reflection of biology, it's a reflection of bias, access, and the structures that shape care. I've heard it directly from my patients. Many describe not being listened to or being told that their symptoms were normal, even as they felt their bodies failing them. Discrimination and implicit bias remain lethal risk factors in maternal care. Equity has to move beyond slogans. It means measurable outcomes, fewer deaths, fewer complications, and systems built on respect rather than assumptions. When equity is measured and enforced, we save lives. According to the MMRC, as we have already discussed today, 83% of maternal deaths in our state were preventable. 83%. That means that most of these mothers could still be alive today. Preventable means deaths that could have been avoided through timely recognition, appropriate transfer, and standardized response. But too often, women's voices are missed, and the system reacts too slowly. I once had a patient who came into the women's emergency department 3 times complaining of shortness of breath. Her first provider thought she just needed an outpatient cardiac workup and prepared to send her home. When I came on, I sat down with her and truly listened. She was Black, obese, and already felt unseen. What she was not was uneducated. She was a respiratory therapist. She knew that the acute onset of this shortness of breath was not normal. Her story and risk factors raised concern for a pulmonary embolism or a blood clot in the lung, and an emergent CT confirmed that. Had she gone home again, she would likely not have survived. That's what preventable looks like. The space between when a woman says something is wrong and when the system finally responds. That near miss taught me something that every major study affirms. Listening saves lives. Dismissal kills. Respectful care isn't just a kindness, it's a clinical tool. When we build systems that prioritize respect, communication, and response, we improve safety for every patient. So what works? We know what works because we've seen it succeed here in Mississippi. When our state implemented the AIM Hypertensive Disorders of Pregnancy Bundle, hospitals adopted consistent, evidence-based protocols for recognizing and treating severe hypertension in pregnancy. Within months, response times improved and preventable deaths from preeclampsia declined. But participation is still voluntary. To achieve equity, every birthing hospital should participate in AIM. Standardization doesn't limit judgment. It ensures that a woman in the Delta receives the same timely care as a woman in Jackson. Our next AIM bundle is cardiovascular disease and pregnancy, and it targets the leading cause of maternal death. If fully implemented statewide, we can change that statistic. How do we close the gap? Rural hospitals are the lifeline of their communities, yet they face very different realities in large centers. Fewer staff, fewer specialists, and limited access to rapid consultation or simulation training. When obstetric emergencies happen, minutes matter, but resources don't always match the urgency. These hospitals deliver many of Mississippi's babies each year. Readiness cannot depend on zip code. We need funded technical assistance for low volume birthing units, simulation drills, escalation pathways, and teleconsult support, so a mother in the Delta receives the same standard of care as a mother in Jackson. Equity means geographic equity, the same protocols, the same thresholds for transfer, the same timeliness everywhere. That is how we close the gaps in outcomes. So Dr. Tucker already talked briefly about Stork, but I have a slide here, and it's one of our state's strongest rural readiness initiatives. It was developed in 2021 and funded by the W.K. Kellogg Foundation through 2027. Stork provides free obstetric and neonatal emergency training for rural hospitals, EMS, and first responders, giving them the tools to manage maternal and newborn emergencies before transfer. So far, it has reached 945 participants across 34 counties through 60 trainings. That's real, measurable capacity built in the areas that need it most. The goal is simple: to improve outcomes for pregnant women and newborns by equipping rural providers with life-saving skills. Programs like Stork demonstrate that when we invest in rural training, we save rural lives. What else can we do? And I know somebody will be speaking on this today, but as you can see, it's a continuing theme across people who have spoken today. One of the most effective evidence-based strategies to improve maternal outcomes is doula care. Doulas provide continuous physical, emotional, and informational support before, during, and after delivery. Studies show that they lower cesarean rates, reduce complications, and strengthen trust, especially among Black mothers. If we could, I would recommend that doula services be covered by Medicaid, that training and certification programs for doulas in this state be funded, and that we can offer voucher options to uninsured women. If we expect consistent outcomes, we must ensure consistent training and scope of practice. Doula care blends compassion with cost effectiveness. It saves money and it saves lives. I had a patient with severe range blood pressures who needed hospital evaluation for preeclampsia. She relied on Medicaid transportation. The driver agreed to take her to the hospital and then drove home instead. That delay could have cost her her life. We cannot talk about maternal outcomes without talking about the barriers that prevent women from receiving timely care. As we've discussed already today, transportation is a big issue, as is childcare, work schedules, food access. Embedded social workers in prenatal clinics can coordinate rides, help arrange childcare, and follow up when appointments are missed. Funding social work positions is a safety intervention. It connects medical plans to real-world logistics, so women can actually receive the care that we prescribe. Maternal health is both a moral and an economic issue. For every $1 invested in maternal health programs, states save an estimated $4 in downstream costs: fewer ICU admissions, fewer readmissions, and healthier babies. Those savings ripple outward: stronger families, more stable workplaces, and healthier communities. When we invest in mothers, we strengthen Mississippi's future workforce and educational outcomes. Healthy mothers raise healthy children, the next generation of teachers, engineers, and leaders who build this state. Investment in mothers isn't charity, it is strategy. Thank you again for the opportunity to testify today. The data we've discussed represent real Mississippi mothers and families, lives that could have been saved. 83% of maternal deaths in our state being preventable means the solutions are already within our reach. I could go on for another hour or more about what more we can do or should do, but I hope that what I've shared today offers helpful, actionable information as you consider next steps. Thank you again for your leadership and your commitment to improving maternal health in Mississippi. Every mother, every time.
Thank you to you both. Any questions from members? Lady from Jones.
Thank you so much for your testimony. I wanted to ask first, Dr. Tucker, what we know, I believe you said we had 6 OB graduates, and of course, you know, we have the rural physicians program that we've been trying to escalate. If you could speak to the legislature and say, what do you think would be helpful, or some funding mechanism that would be helpful with helping to replenish or train more people in obstetrics and gynecology? What would your recommendation to us be?
Yeah, and is this microphone working now? Is that better? Okay. So that is a great question, and from a legislative standpoint, I'm talking about Mississippi legislature. I'm not sure that anything you all could do would move that needle, in the sense that we are limited by governing bodies in graduate medical education to the number of residents that we can train, okay? And there's several parameters, and much like Dr. Bell said, I could probably talk for an hour about that, but just in summary, it has to do with number of faculty, number of deliveries, number of surgical cases, the clinical experience these residents get. And so 6 is about the max that we can do as we sit here in 2025. We are looked at every year to make sure we fall within those parameters. Having said that, there are a couple of other things I didn't mention that we've done over the last couple of years. One is that we added what's called a transitional internship year. So we have a 7th intern that joins us every year, trains an OBGYN. At the end of that year, if there's a second-year spot either in our program where somebody has left or in another program around the country, they can go into that program. If they're recruited, apply to that. So that would be a spot that is only one, but 1 + 2 is 2, 2 + 2 is 4, and eventually, if you look back in 10 years, you've trained 10 additional OBGYNs that started in Mississippi. So they can go somewhere else and go in the program. The other thing that we are actually going to match our first intern in this year is we partnered with Gulfport Memorial, which strangely enough is designated as a rural center, to start a rural track residency. So we'll have one extra resident that will come through that program that will start in the summer of 2026 with us, and then we'll graduate our first resident out of that. So eventually, by 2030, we'll graduate 7. That extra internship that I mentioned. Other training opportunities, certainly we do not have a nurse midwife training program right now. Really no plans to do that in the immediate future, as we're focusing more on the clinical side. But eventually, if my bosses at UMMC decide that's something we want to pursue, then that would be something, I think, from a legislative standpoint, that funding and support would be necessary or maybe asked for.
And then, let me ask you this too, and thank you. In the family medicine space, if the legislature were of the mind to increase the number of physicians that, we are in the rural physicians program, do you think that would be something that would help us with this situation with maternal health and infant mortality? And if you do, about how many more slots do you think we ought to be increasing it to in and around family medicine?
So that is another great question. There are a few people in the room that remember, like myself, the days when lots of family physicians delivered babies. That's just what they did as part of what they do in their practice. Over the last 2 to 3, certainly 3 to 4 decades, that's kind of gone away. So obstetrical training in family practice residencies is not as robust as it once was. There are some 1-year fellowships where after a 3-year family practice residency, someone can go back and do an obstetrical fellowship for a year, learn about low-risk deliveries, learn about high-risk pregnancy management, learn how to do cesarean deliveries. And that, I think, is a viable avenue to help with the workforce. I really can't speak to the number of slots. That would be, anything I told you would be just a guess. But, once again, if we train one family physician in obstetrical care, that's better than none. And so you got to start somewhere. I'm aware that there's a program over in Meridian that has started. I'm aware that there are other places around the state looking at this with respect to family medicine training in obstetrics. So I do think that that's something that we're going to have to look at and support as we go forward in this workforce crunch that we're in now, and likely is going to get worse.
And then, thank you. And then my final question to Dr. Catchings. Of course, you will remain in Mississippi. That goes without saying.
I put a lot of pressure on her this morning.
We're going to do all we have to do to make sure you stay. But I want to go back to when Dr. Owens was talking about the collaboration. I am concerned about making sure that we utilize everybody that's out there. And, Dr. Owens said, well, one thing we don't know is who's out there. So probably somebody somewhere needs to find out who's actually out there. Okay, now, once we determine who's out there, has anybody given any thought to maybe creating when I was in nursing home administration, we had a checklist. When we looked through charts, we went down the list, and that's how we made sure everything was there. Is it anybody that could create some kind of checklist that says that if we've got community health workers, if we've got home aides that are in homes, if we've got police and fire, you know, if we've got, I mean, I just don't know, whatever it is that we think that could work, you know, in this whole space. How would, has anybody given any thought to creating something like that? I know we're gonna have our OB trauma, but do you understand what I'm saying? The basics, like you said, you can get the basics in Jackson, the basics in Laurel, or the basics in Alligator. Has anybody thought about that?
I'm sure plenty of us has thought about it and having to figure out how to make that work. And one thing that I know that we are piloting here, and Dr. Tucker might have more information than I do on it, is pregnancy centering that one of our midwives is heading now. And it's where it's like a group of mothers are put together who all have similar delivery dates. And they come and they have visits together, and they can see social workers at the, like all in this, like it's like a medical home, but centering for pregnancy. And I think that's one of the ways that we can start with this, because it brings people from different avenues. It can bring the doula, it can bring the midwife, it can bring the social worker, it can bring the mental health person, all to this one place where these people come. And if we can pilot it successfully here, then maybe it could be able to be taken into more rural areas.
And then on the midwifery, the whole midwife discussion, you all would be in support of creating a protocol and something acceptable so that we could get midwives, doulas, all of these people certified, licensed, and that they could be paid through our insurance entities.
Yes, ma'am. We would be supportive of anything that would help our workforce issues, as long as it's safe, effective obstetrical care. That always has to be at the front. Just because someone's licensed doesn't mean necessarily things are safe. So we would be in support of that. If I may digress for just a second, you hit on something that's very near and dear to me. As far as figuring out what's going on out there. Our School of Population Health actually scratched the surface on this. If you go to their website, they've got I'm gonna call it a heat map, for lack of a better word, that went over the state of Mississippi and showed where one could get prenatal care in a particular area. Everybody in this room has a doctor. If they have a problem, they call their doctor. If you're in rural Mississippi and you're 20 years old and you're pregnant, you literally don't know where to call or who to call. And so having just a minimal, simple resource like that, where somebody could call, and if that person doesn't know, then they could get you to the next person, the next person, the next person. But like you said, it'd be nice to know these other things even more granular than what the School of Population Health did. Social workers, behavioral health specialists, community health workers, all those things that kind of flow down from that would be ideal. The problem with that, we can do it today as a static document. You literally have to keep up with it every month, every quarter, every year, because it changes. Somebody will be in business today, and then in a year, that clinic is gone, or the providers there are different, or whatever. So keeping up with it and making a living document as opposed to a static document is sometimes a huge challenge. But to our School of Population Health credit, at least they started that with the concept that you so eloquently described. Thank you.
Thank you. Thank y'all for your testimony.
Thank you, lady from Jones. We have a question from Representative Faulkner. Gentleman from Marshall, go ahead.
Thank you, Madam Chair. My question is for Dr. Tucker. Thank you, Doc, for your testimony. You mentioned about a pilot program that was going to have about 250 participants. Is that correct?
Yes, sir.
My question is, I'm just curious. Is there a price tag associated with that program? And if so, is those monies coming from the medical center appropriated by the legislature or not?
So that program actually was started with some grant money that we got in the Department of OBGYN, and it was just like two ships passing in the night. The grantor came in and said, we've got this money into the year, do you have any use for it? And I'd been kind of thinking about this program for some time because I'd been approached by this company and didn't have the funding. So we were very fortunate to be able to get this up and running in a relatively short period of time. It's over 2 years, and the 2 years will be supported by the grant money. Our hope is that we will not only, first of all, be able to show it's beneficial for the participants, but you know, everything else, it all comes down to money, that if we can show that it's a cost savings for the system, our hope is that either through the medical center or through legislative action or for future grants that we can continue this program. But we just started this in July, so we're good through the summer of 2027. Thank you for that question. It comes down to money.
Thank you.
We can show that it's a cost savings for the system.
First of all, thank you all for your presentation. I want you to, Dr. Tuck, to go back to your conversation about first responders. And how can we expound on that to offer more training to them, particularly in the rural areas? Can you kind of expound on that? I think you said it was about 1,000. How many did you say?
I said 1,000. Dr. Bell said 945. I embellished it a bit. 1,000 sounds better than 945. So.
But I really think that's a real important component as far as being trained in this area. Can you kind of expound on that a little bit, please?
So do we have handouts that we can, they have them that provide as far as the STORT program and all, and I'm gonna have to give a shout out to Dr. Rachel Morris. This has kind of been her baby and her passion for the last 4 to 5 years. She came to me with this concept, and the emergency management people had brought it to her. And the whole concept is to, rather than saying, okay, we've got a training program here in Jackson on Saturday, y'all come down, we take this program out to the sites, to the rural hospitals, to the rural ERs, to respiratory therapy units and all. And one of the first things that was noticed is how hungry these people were for this training. No one had taken the time to come out and say, okay, here's how you manage an obstetrical emergency. Here's how you manage a baby that's born, especially a preterm baby. These events, fortunately, don't happen every day in these rural settings, but when they do happen, it is a very, very, very stressful type of situation. So going out, and you saw the map to where all they had gone out to, and it's just pretty amazing over the last 4 to 5 years who all they have reached and how hungry people were. To your specific question, this too has been a grant-funded type of operation. So going forward, and I would be speaking out of school if I said exactly what the current funding is and the mechanism, but at some point that funding will run out. Having more teams to go out and reach more people, stating the obvious, would be a win for that program. Basically, they have one team, and one team can only do so much. If we had 2 teams or 3 teams or 6 teams, obviously we can reach more people. In addition to that, training is static, just like that other thing I mentioned, that training changes and people need refresher courses. So it's not something that we want to train 1,000 people and then stop. We've got to retrain those people, and we've got to train other people who come into the system.
Would you be willing to give, is it something that we need to incentivize as far as getting that specific training? And the reason I'm asking, this is a true story. About a month or 2 ago, I was in a grocery store, and a fireman was talking to me, and in conversation, he said he had already delivered 4 babies this year. And I'm in Lowndes County, Columbus, the city of Columbus, so I can just imagine what that would look like in rural areas. So I just think that's an integral piece that we really need to look at, not trying to supersede or take the place of any doctors, but it is a sort of a safety net that needs to be considered.
I would love to get Dr. Morris on the phone so she could hear what you just said, because she'd be turning somersaults. I think that is a great idea. The only deal I'd make with you, if you would include my folks in Monroe County and Aberdeen and Amory, along with your folks in Lowndes County, I'd be appreciative of that too. So.
Yes, sir. Thank you all.
Well, I had a question. But no, thank you very much. We've heard testimony around the fact that, you know, Black women and Black babies are disproportionately dying. We've heard about the need for cultural competency training with our health professionals. Is there an opportunity, Dr. Tucker, to have some partnership efforts with our HBCUs across the state? Mississippi Valley State is in the Delta, in the heart of where we have these high rates. I appreciate you having an internship program on the Gulf Coast, but when I look at the map that was provided by Dr. Edney, those rates are much lower, dramatically lower than what we see in the Delta. So is there an opportunity to do some work with our HBCUs?
Absolutely. In the School of Medicine, as I'm sure you're aware, does have some of those. And we, you know, my philosophy is that, you know, I don't start recruiting an OB/GYN resident when they're a fourth-year medical student. We start that when they're a third year, a second year, a first year. And so if that works better for getting folks into the program, why don't we start when they're in college or even in high school or in junior high and work backwards? Because the earlier you can reach these students, get them interested in medicine, and more particularly in OB/GYN and more particularly in women's health care, that's a win-win for everyone. So very simple question, a very simple answer. Absolutely, we would be very interested as a department in partnering with anyone who wants to help with this problem.
Very good, thank you. I know that UMMC administers the Mississippi Rural Physician Scholarship. The lady from Jones talked about that. We try to increase the number of scholarships that we could give to students. And they had I guess what you would call also a heat map, where those physicians were not being sent to rural areas in the Mississippi Delta. So I'm very happy to hear that you are in support of that. Dr. Ketchings, you've shared a myriad of solutions that we should take a look at. What part of the system should be prioritized for redesign?
I think because most of these issues are happening in the postpartum period, that's the part that needs to be prioritized, is how we manage postpartum care, right? Because as Dr. Owen sat here and she was talking about her definition of a desert, when you have to consider, I'm going to go and talk about transportation to and from appointments, okay? So when we as physicians take call at hospitals outside of the university system, you are supposed to live within 30 minutes of the hospital in case of emergency. So just consider people who live in these deserts, okay, where even if the hospital is 40 minutes away, if you don't have a car, you have to call an ambulance, that's more than 30 minutes, right? And so I think we need to try to see how we can institute change as far as getting transport to your appointments, allowing child care for other children during those appointments. How can we facilitate these patients being seen so that when the emergent healthcare needs appear, they're able to be appropriately taken care of, and preferably before it reaches the urgent state, okay? So if your appointment is in 2 weeks, okay, but you don't have a ride to that appointment, what are we going to do about that? So, and I also I know that they talked about vouchers, but think about taking an Uber from Belzoni to Jackson. Like, that's ride share from Belzoni, Mississippi to Jackson is not really, it doesn't make a lot of sense. So one thing that I really think should be considered is taking the care to the patient. And thinking about how we can get people together, these teams that you were talking about, Representative, to go to these patients' houses and give them the care there if that place that they need to go to is more than 40, 45 minutes away. And so that's the part of the system that I think that we should focus on at this time, if I had to choose one thing, merely because most of our deaths are happening in the postpartum period.
Thank you.
You're welcome.
Any other questions from members? Anybody online? Thank you to you. Thank you to you both so much.
Thank you.
I also want to recognize that the Vice Chair of the Mississippi Legislative Black Caucus has come in, Senator Rod Hickman. Thank you for being here. We're going to ask that Dr. Burse and Brittany come together, if you would, please. And Representative James Jones is going to introduce them.
Thank you so much, Mr. Chairman, as well as Representative Summers. We introduce now is Dr. Nikitra Burst, who's a founder and executive director of Six Dimensions, a Mississippi-based nonprofit dedicated to providing maternal health outcome. She's a servant in the field of public health and has been for more than 15 years. Dr. Burst is dedicated to understand the impact of systems on health care, on the care of communities. Her work centers on health equity and improving maternal health outcomes for Black women. She also serves as a Mississippi Maternal Mortality, serves as a member of the Mississippi Maternal Mortality Review Committee. Brittany Eisler is an international board certified lactation consultant, certified birth doula, and the owner and founder of the Delicate Moments Lactation and Doula Services. A Shaw, Mississippi native, Brittany is deeply passionate about things related to birth and lactation. Her mission is to bridge the gap in maternal and infant care by providing compassionate, culturally relevant, and evidence-based support to families through the Mississippi Delta. She strives to empower mothers with knowledge, confidence, and community, ensuring that every family, regardless of background or income, has access to the care and education that they deserve. Ladies and gentlemen, Dr. Burst and Ms. Brittany Eisler. Thank you for coming.
Good afternoon. Can y'all hear me? Okay. Good afternoon. Thank you to Mr. Chairman for having us. Thank you for Representatives James Jones and Representative Summers for having us and hosting this timely conversation. It is something that we've been talking about for many years, and we're happy to see much light shed on this issue. I debated on whether or not I would come here as a public health professional or a family member who has been affected by maternal and infant, maternal morbidity, mortality, and infant death as well. And so I decided that I can't do one or the other because they live together. And so my discussion here will be a little bit about what you've heard, some of what you've heard before, but also about solutions that we see from a community perspective and a family perspective. And so with that, I would like to recognize that being here is not because I want to be, it's because I have to be, and it's a part of my passion and calling. And so I have to recognize how I got here. My dad is here. He is an alderman in North Mississippi. And he works also to recognize, he recognized Black Maternal Health Week this year, so we are thankful for that. My mother is a retired nurse, school nurse, and we heard talk about school nurses, but she also cared for or raised my aunt's son who died after giving birth. And my stepmother is also here, who is a retired educator, and she worked with special needs kids in the public school system in North Mississippi. And so I appreciate them being here, and they have helped shape how we have to do this work and why we continue to do this work. Now, I said 2 retired, 1 still working, so I don't know if he's gonna stop working. So we talked about who we are, but I don't want to belabor the data because this is the exact same data that you've seen before. Serving on the Maternal Mortality Review Committee is the unpaid job that is my service to the families and families like mine who did not have any answers or any reprieve after the deaths that we have seen. But that preventability number, when we deem those preventable, as many have said, being able to prevent this is why we're here. And so I hope that we can talk about some solutions and in a very practical way. And I also cannot have this conversation without talking about the history of racism in maternal health. At our organization, we do believe that history is a determinant of health, specifically for Black women. And so we talk about disparities, but we focus on those inequities, which are rooted in systemic racism. And so often we think about racism as these interpersonal things that happen when you go to a healthcare provider, and that's that. Maybe you're not listened to in the healthcare system, but we don't give enough light to how the systems were built, and they were built for Black women particularly not to be able to navigate them with ease. And so I've pulled out a few things because you all will not give me time to have a history lesson. But when we talk about Black midwives and what the midwifery care model looks like, it originated from our people. And so bringing those practices here to a country to integrate into systems is tough. And so as we advanced in medical care, then Black midwives were pushed out of the system. And so that's a part of why we are having this discussion, and we keep hearing the question about midwives, doulas, and what their role is, but we have to look back at history. And then biases in healthcare continue to impact outcomes today. And so we've heard about where Black women may say they have experienced, they were not heard or listened to in the healthcare system, but that's documented in the literature. And so these are not just things that we are anecdotally saying, but they're also documented in literature. When we discuss low breastfeeding rates among Black women, we have to remember that enslaved Black women were wet nurses and were not able to provide nurture for their own babies. And then access to quality health care. We talk about health care, but what about quality health care? Going to a provider and having the autonomy to choose the type of provider that you want, the healthcare team that you want, and that autonomy was taken from Black women when we were brought to this country. And then representation in the workforce, as that directly ties to Black midwives, it also ties to our Black healthcare providers. Very happy to see Dr. Owens, Dr. Bell Ketchens, but there's also literature to show that when Black women are paired with Black women providers, our care is much better. And so we can't move on with this discussion without remembering that history is why we're here. And so a little bit about my story, or my family story, and how I got here, and the generational impact. So October 6, 2006, my aunt in North Mississippi died from pregnancy-related complications. That's her in the middle, and as you can see, she was good and pregnant, so this wasn't a preterm birth. She was a social worker. She had a master's degree, undergraduate degree from Mississippi Valley State University, master's degree from Jackson State social work program. And part of that, she was not listened to in the healthcare system. My mother was a nurse. We had another aunt who was also a healthcare provider, a doctor. She wasn't listened to in the healthcare system. And on each side of her, you'll see my sister and her husband. And today is the 9th anniversary of my nephew's death. He never got an opportunity to experience life outside of the NICU at UMMC. They did provide amazing care to our family, amazing care. But when we talk about OB deserts, they live in Starkville, and having to ride 2 hours in an ambulance to get here, we don't know if that had any impact on their outcomes of care. So my sister had to ride in the ambulance back to Jackson. So our baby stayed in Jackson's NICU at UMMC for the duration of his life. And so the two pictures that you see at the bottom on each side, my sister-in-law, Shantee Walker, and her daughter, Nakiah Walker. Shantee died in 2016 as well, 3 weeks after giving birth. And she was 26 years old. And so the impact of this is generational. It presents not only mental health issues and grieving and the economic impact. My mother didn't have to buy diapers for quite some time because the community came together, but she was also a single parent. And so this maternal health is not just about the clinical care. It's not just about someone getting into prenatal care. It's about the systems that we have designed and the solutions that we put in place to fix them. And so I do want to mention my brother, my aunt's son. You can see him down at the bottom, 22 years old now, and he's working, growing up. We still trying to keep him in line, though, y'all. So for some solutions to not to belabor time, of course, you've heard the maternal health workforce. What we believe is that families should be able to have and develop their maternal care team as they see fit. And so that means investing in doulas, lactation consultants, midwives, and other public health professionals. There is plenty of literature to show how doula guidance and perinatal care is associated with positive delivery outcomes. That's not only for cesarean births, but that is also for mental health issues, and having a doula around to be able to support just the basic needs of mother, whether that's bringing a meal or sitting with the baby while mom gets a shower. Those things are very important. And our community-based solutions. We run a community-based organization, but we don't provide as much direct services as many of our partners and friends do. We are fortunate to be housed at Magnolia Medical Foundation, who does provide those services. And what we see, and among many of our other community-based friends here, is that we're bearing the brunt of what's happening in the systems. We're getting the calls. We're having to navigate the system. We're having to help meet basic needs when it comes to lights, gas, water, utilities, jobs. Those things we're bearing the brunt, and what we're doing is making a way. We're trying to figure out how we meet those even when we don't have the funding. And so when we talk about collaboration, we're here. Our organizations are here, and we know how to get the resources to community. We just have to be at the table. And then removing financial barriers. We've talked about this for many years, but Mississippi has the highest, with Tennessee as well, sales tax. We know at 7%. But taxing diapers and menstrual products at the same rate is not following along what some other states are doing. Some states have eliminated the sales tax. We are treating this like luxury. Everyone has to diaper a baby. Every baby has to have a diaper. And so what happens when we remove that tax? We have increased work productivity. If that baby has a diaper rash, mama's not getting any sleep, and mama can't go to work, and mama and daddy, let me say that, both parents are not being productive in work. And also, when we remove that tax, we are able to decrease some of those health risks. Diaper rash, keeping a diaper on for a long time, we know, many of us know what that is like. And then better maternal mental health. When that baby is crying, we're all tired, we're all mad. And so what are some of our policy solutions? These are not solutions that we just pulled out of the air. They came from us talking to organizations, us being in community, and us being on the ground seeing what needs to work. Establishing workforce pipeline programs. What we see a lot with doulas, and Brittany, you may talk to this too, is that a lot of folks come into the area because they've had an adverse outcome in some way, but then they still need other pathways. They don't get paid nearly the rate that they should. And so some other pathways are also around being able to bill, of course, with Medicaid and things like that. But also, if they want to go into nursing, how do we create that pathway for them to have other careers in the medical field if they so choose? And then expanding Medicaid and reimbursement for doula and midwifery care, funding community maternal health programs, and again, removing the sales tax on essential family products. And so these things we believe are from a community perspective that can help alleviate the burden and also really connect us more to the systems of care so that we can help navigate families better. And so as I end, this is a moral issue, and protecting Mississippi's mothers. Representative Summers said earlier, when black women thrive, we all thrive. And so this is a picture that I just like to end with of my aunt, my sister, and I think I was missing a few teeth on that one, but she was gone far too soon. And that's the reason that I do this work, and that's the reason that I'll continue to do this work. Thank you for your time.
name is Brittany Isler. I am a lactation and a certified doula. I am from Shaw, Mississippi, born and raised in the Mississippi Delta. I am a mommy to 4 amazing children. I'm a wife as well. And I come to this line of work based off personal experiences and then being in the community, seeing the need. As I said, I have 4 kids, and no same doctor delivered my child. I knew early on. I didn't know anything about doulas. I didn't know anything about advocacy, but I knew that I knew how to stand up for myself. I knew what that looks like in all of the areas and relationships except with my provider, right? Where it matters. And so with my first baby, first time mom, I didn't know. I just listened to everything that the provider was saying. And to this day, I really believe that from not having that voice everywhere except in the provider's room, that really cost my child. She actually has a birth injury, which is called brachial plexus. And so thereon, after those, after her birth and then all the other kids' birth, I just knew that there was something in the care of each of the providers. I was like, we need to talk about this more. And so in the birthing processes and the deliveries and the postpartum, then came breastfeeding, right? I ended up breastfeeding my kids. I breastfeed my babies until they're 3. And I noticed that I didn't have that support or that help that I needed, right? I remember looking on social media, and I never saw someone breastfeed that looks like me. So I started the journey of becoming a CLC, and then I started learning. I was like, let me start posting my journey on social media, and that's where it began. Other moms started to reach out, like, hey, Britt, I see you're breastfeeding, asking questions and things like that, and so I wanted to further, and I wanted to kind of get in the community and show moms that we do breastfeed. So being a first-generational breastfeeder, there were a lot of barriers that come from family, from friends, from the community. It was just like, why are you doing that? You're doing too much. But I didn't listen to the naysayers. I actually learned more and more, and then I take very much pride in being on the ground, in the trenches, in the Mississippi Delta, educating moms on human milk, because that's very, very important. Human milk is very important when it comes to all other things, all the Mississippi crisis. We're talking about maternal health rates. We're talking about infant mortality. It's connected. It's connected with human milk. If we would breastfeed our babies, that would lessen the chances of a lot of these diseases or sickness and SIDS and stomach issues and all the things that's going on with our babies. And so also birth workers, doulas. If we were to prioritize our mothers having that support, it is very important. It is not a luxury. Every mom deserves to have a doula. A lot of times I say that the birth work, it starts well before the delivery room. We are building that relationship with the moms. We are learning things. We are asking questions. My clients have homework. You have to ask your doctor at least 3 questions. I don't care what the questions are. You have to get engaged. You have to, and we work together with the providers. One of the misconceptions is that we deliver babies. We do not. We do not. We are, I like to say, we are up top, right? We are supporting the moms mentally, physically. We're educating them. I'm very big on education. Right, so we're teaching moms things that they didn't know, things that the providers may not have time to even discuss or talk about. And so doulas, that's what we do. We are educating the moms. The magic happens well before the moms gets into the delivery room. And in the Delta, where their maternity deserts, and that the cares or the NICUs and things are 2 hours away. Either we have to go to either Memphis or we go to Jackson. I think that all moms, it should be prioritized that they have doulas. So one of the things about, I say that a challenge for Mississippi is that we as private practice doulas, we are receiving little to no pay. If all the moms are on Medicaid, they really cannot afford that service of having a doula, right? So some moms are being turned down. I mean, even the high risk, the highest of ones that really need that attention, they are being turned down because private practice doulas aren't reimbursed. They're not being reimbursed, and so the moms are having to come out of their pockets, all right? And so we're talking about the Mississippi Delta. We're talking about moms who are on Medicaid, low income. And so that is an issue. And so I really feel like there can be a policy change where that doulas in the state of Mississippi should really, really be reimbursed by Medicaid. So some policy changes or solutions that I recommend is that first creating a Mississippi doula registry. So that way you would know who are the trained doulas, who are the certified doulas, like you would know who we are there, you know how to access us, right? And then I say that authorizing Medicaid reimbursement for doula care, right? So this is really, really big. So just like a mom who is on Medicaid, she is going to her provider, she's going to her appointments, she doesn't have that burden of paying. So as a doula, we are not, it's not a luxury, it's really a necessity. I can't stress that enough. Like every mom deserves to have a doula, especially if she wants one, right? So, including private practice doulas. We've talked about community health workers doulas, but what about the private practice ones, right? What about us? We think we are on the ground, we are doing the work, we've been doing the work, we're already doing the work, right? We've done the trainings, we've been doing this. And then I really feel like private practice doulas should be in the conversation as well as reimbursement. So, and establishing fair rates when we are talking about reimbursing doulas as well. And then the last, combining doula and lactation support. That goes hand in hand, all right? If we are having more moms educated on breastfeeding, right, and then actually breastfeeding, that changes so much. Excuse me. So a mom who breastfeeds, she is less likely, if say we have a mom who has gestational diabetes, right? If she breastfeeds, she is less likely to have diabetes after she delivers. She's less likely to have cervical cancer. She's less likely to have any type of cancer. She's less like there are so many benefits. We talk about the baby and the mom. There are so many benefits. If I were to name them all, we'll be here all day, right? So the answer to a lot of what's going on is human milk, first off, right? If we would get human milk into these babies. And so we say human milk, right? So we know breastfeeding is a natural thing, but it's not always easy, right? So we're gonna talk about human milk. We should talk about their education, having access to lactation consultants. Previously, I was a DBE for the Mississippi State Department of Health, but the contracts were cut, and so I no longer work at the health department, and also that means moms in the area aren't getting that lactation help, right? So what does that leave? So we're talking human milk, but there are moms in certain areas who are not getting that lactation education, right? So there comes where the private practice is, right? So that's when Medicaid and should definitely have doula care and lactation support all in the same. So every day in the Mississippi Delta, I'm seeing it. Some moms have to be turned away. It's a lot. And then I always say, I think I actually was in a training with 6 Dimensions, and it said that you should definitely get paid for your passion, right? It's my passion, but we should definitely get paid. You get burned out, right? It's just so much, and I don't want to get emotional, but I am in the Mississippi Delta, and I see it. I see a mom who was birthing for 2 hours, and she broke down, and she was like, I'm just going to get a C-section. And I'm like, what did we talk about? What are the things that we went through? And she labored 2 days, and the doctor, the provider was like, you know what, the baby is stopping. She was like, well, Brittany said there's no such thing as stopping, and she actually ended up delivering vaginally because we talked about this. We make this it's better, it's way better to make this relationship when instead of in the doctor's office, it's way before. We're building this relationship with them. They trust us, right? It's not just in the moment, at the doctor's appointment, 5, 16 minutes. Like, I'm asking you, what did you eat today, What did you drink today? What's your fiber intake? All of these things matter when it gets to the delivery room. So doulas are very, very important. And like I said, in the Mississippi Delta, it's hard. It's really, really hard. And like I said, I really, really, really honestly believe that human milk and birth workers are all can definitely, working together can be the solution to the problem. That's all.
Thank you so much, Brittany. Thank you, Dr. Burse. This is an emotional issue, so we appreciate you being authentic and genuine in your testimony today. Are there any questions from members? Lady from Jones. Gentleman from Lee.
Thank you. I thank both of you ladies for being here today. I just have one question is, how do we navigate to include fathers in this type of things? Because I see here we are dealing with moms, but you know fathers do have emotional attachment also. So how do we engage in something like that to make sure that we include in part of the process?
So there are quite a few organizations, including ours, that are exploring the best way to engage the whole family. And many organizations here, I know we keep talking moms, but most of the organizations here do include it as a family model of care. Because one thing that we believe is when an issue happens, somebody's got to be able to speak up. Somebody's got to be able to advocate for the family. And so there are many ways that fathers can get involved, and part of that is being there. Being there at every appointment when possible, being educated on the issues, sitting in some of these conversations that we're having, attending the doula appointments so that they can understand what's going on as well. But I also think a part of it is that we have to change our language. We do. We have focused a lot on moms. Especially Black women, we focus a lot on moms, but we do have to start changing our language to be more inclusive of families and bringing partners in and fathers, husbands, all in the realm of this.
Thank you.
Lady from Humphreys.
Thank you so much. I just want to say to both of you all, I truly appreciate your passion that you've brought to this table today, and of course, definitely appreciate your work. And of course, from Shaw, Mississippi, you know that I'm right down the road at Belzona. So I'm so grateful for your passion, and I'm so grateful for your work. And either of you can, well, more Dr. Burse, let's just talk. With your phenomenal program that you have here in this area, how important is it that we have similar programs in areas such as the Delta? And when we think about it, I try to think in the reverse. In many areas, there are lack of grant writers that can get programs in our counties in the Delta. But are there any incentives to bring your phenomenal program to our area, or any partnerships that you may have that would be interested in coming further north of here?
Yes, so I will say that we are not bound to the Jackson area. We'll come wherever you need us. But the other part of that is the only way that we can do our work is through partnerships. We partner throughout the state as much as we can, but you bring up a valid point. Throughout many areas of the state, you won't find many grants that say focus on Northeast Mississippi or focus on other areas in the state. It's mostly here, the Delta, and some along the coastline. So we're still missing a lot of folks in places that need care, and we've seen that from some of the data, but we are open to supporting organizations all across the state.
And also, Ms. Easler, just wanted to know, is it difficult to connect those programs? I know that you said you were a former employee with the Mississippi Department of Health, but some of the other programs, is it difficult to make those connections, or are you finding a pathway to make those, to put those dots together for any other programs that you may have in your area?
Are you saying as far as?
So if there are other partnerships, do you all collaborate as well? Do you consider having collaborations in
Yes,
your
yes,
area?
yes. As a private practice, I think 3 years now. So yes, we collaborate, and then most of with my private practice, I do mostly group education, right? So that way moms don't really have to come out of pocket, and so I give funding or whatever so that they could get some type of education. They may not get that one-on-one doula care, but they're able to get some education, knowing some things when they get ready, to deliver.
Thank you so much for coming.
Thank you all so much. We're going to take a 5-minute break and allow our caterers to set up. In the meantime, we're going to ask Cassandra Welchland to come forward. We'll be back in about 5 minutes. Thank you.
Let us come back to order so we can go ahead and we want the presenters to take their time and present, but we are dealing with time constraints. Representative Summers, you have the floor.
So in other words, let's keep our presentations and questions brief. Thank you, Cassandra, for being here. Ms. Welchland is the Executive Director of the Mississippi Black Women's Roundtable. Mississippi BWR and Six Dimensions are our partners for our legislative hearing today. We thank them so much for their support. Ms. Welchland, you have the floor.
Thank you. Good afternoon, and thank you to the Mississippi Legislative Black Caucus for having such an important conversation right now. I want to anchor our conversation around the intersections of race, gender, and economic justice. And we've heard a lot of this from Nikitra and some of our other partners that have spoken here today. And so I will talk about that, just really centering the economic justice lens of this. So we know that, and we've heard this, a mother's well-being extends far beyond just her personal life. It impacts families, communities, and businesses. The workforce is so key and important to this. Again, when women are physically healthy and financially secure, that helps businesses. And that also means that her dollar is turning over in that community over and over and over again, because she has income coming in. But if she's sick, not well, not here, then that income is depleted from that community. And so too often people are forced to drain their savings, if they are lucky to have savings, or even lose their jobs when they are caring for a child, caring for themselves, or caring for others. We know that, you know, women and birthing people are really caregivers for their communities. And so no one should have to put their financial future at risk to welcome a new baby, to care for a loved one, or to recover from illness. So I want to talk a little bit about why this matters to Mississippi. You all have heard the data. I will just speak to what we have not talked about. During the pandemic, it was really exacerbated who was on the front lines. And it was women on the front lines in jobs, low-wage jobs. Women, you know, they dominated these frontline jobs, but they lacked paid leave, they lacked affordable child care, they also lacked what we called, you know, just good wages. And so we're talking about, let's put a face to who we're saying. We're talking about child care workers. We're talking about community health workers. We're talking about cashiers. We're talking about restaurant waitresses who take care of us. And so the economic loss perpetuates generational poverty, and it persists without a lot of intervention. And so what we want to really stress here is that, you know, the cost of inaction equals economic losses, higher healthcare costs, and generational poverty. And Dr. Catchings really talked about that. What is the number to the lost? When we lose our women and our moms, what does that economic loss look like? And so it's really significant. So let's talk about the economic burdens on poor maternal health care. So the U.S. loses $6.6 billion annually in costs and loss of productivity due to poor maternal health outcomes. And so basically what we're saying is, when a mom or a birthing person is not at work, you know, the economy is losing because she is not at work. Preventable complications lead to higher emergency visits and income loss. And so what that means, higher emergency visits means medical debt. And we can't tell you how many times we've heard from some of our partners about medical debt. And it is really, and it continues to make it difficult for them to make ends meet. One of the other things around the economic burden is, 1 in 4 mothers return to work within 2 weeks of postpartum. That is significant, and it shouldn't happen, which is why we need policy solutions like paid leave. Families without paid leave lose an average of $3,000 in annual income. That is significant. Again, we talk about when moms and birthing people are not in the workforce, that has significant impact on that local economy and on that woman's and that household's kitchen table. Dr. Burst did a really great job in really talking about the intersectionality of some of the issues here, and particularly lifting up racial and gender bias. And so I just want to put all of that together for us. So the root causes at the intersections: economic security, low wages. Mississippi, we still have $7.25. No one can make ends meet off of $7.25. It just is, it's impossible, right? And so no paid family and medical leave, even though Mississippi passed the parental leave, we need full paid and medical leave for everyone. The other thing, child care costs. We know we're in a child care crisis, and it can exceed over $5,000 a year. Maternal health, the intersections, the root causes, limited access to health care. We've talked about all of these things today: lack of health care coverage and the high cost of premium copays, which we're going to see even more given H.R. 1 and also given the federal government shutdown. And people are going to be enrolling in the marketplace in November 1. And those premium costs are just going to go up significantly, and particularly for families who don't make enough money to qualify for Medicaid, but yet they have to pay for their own health insurance. And racial and gender biases. Dr. Burst did a great job in talking about this. When we talk about systemic racism and biases, we're talking about not being believed, but we're also talking about what that looks like in the workforce. And so we're talking about low wages or the gender pay gap. And you all, I've brought this before you all over the years, the importance of having a good equal pay law on the books that will close the loopholes, that will stop pay discrimination, because women are losing an excessive amount of money every year because there is this gender discrimination in pay. So let's talk a little bit about what that looks like on families. So 2 of our family members, they didn't want to be identified, and so we're just calling them Alyssa and we're calling them Danielle. Danielle, 27, works at a diner. She makes $10 an hour. She has no paid leave and depends on others to transport her. She risks her job to attend prenatal visits and returns to work 2 weeks postpartum, still recovering and stressed. We have heard this story. If you don't know Danielle, you have a Danielle in your communities. Reality 2, Alyssa, she earns a livable wage, she has paid leave, she also has reliable transportation and a network. She attends all her prenatal visits, recovers fully, bonds with her baby, which is so important, and she returns to work healthy, confident, and she's able to go back to that job without her employer saying, you can't come back due to pay discrimination or racial discrimination. And so these are some of the things that are just so important, is that we have to have a cadre of policies to help women. So it's not just about that, the healthcare coverage, it's the string of the policies that we have to co-create together in order to make strong babies and healthy moms. Policy solutions, a lot of my colleagues have already talked about these policy solutions, but some that we have been pushing at the Mississippi Black Women's Roundtable with our partners, again, paid family and medical leave. We know that's key and that is so important. We're going to be coming back to the legislature this year. Our partners here at this table have helped us push paid leave and medical leave. We're talking about, if we want to have a true paid leave, we're talking about 12 weeks. 12 weeks of paid leave so that moms and birthing people have time to recover. And we want it for everyone. Postpartum Medicaid extension, affordable child care access. And we know that the Mississippi Department of Human Services has TANF dollars that can really incentivize and boost up the child care subsidy program so that moms can go to work and their babies can be in a safe place. Fair pay policies, pregnancy and postpartum workplace accommodations. I want to add this. The federal government passed a bill called pregnancy accommodations. And the Mississippi legislature in 2019, we brought this bill before you all so that we can have it passed here. We didn't get it passed here, but there was a lot of momentum. What that means is that when this contributes to healthy moms and strong babies, when a mom is at work, the employer now must give her, and it's law, special accommodations. So if she is a cashier, they must provide her with frequent breaks. They must provide her with a chair. They must provide her with flexible schedules so she can go to her doctor's appointment. It is law that employers must do these things. We would love to see it even strengthened here in Mississippi, where those who are having miscarriages, they're able to take off work as well. And so doing that wraparound service so that she can be healthy for herself and healthy for her mom. So those are some of the things that we want to be able to see. And so, you know, when we talk about the Mississippi momentum, how have we gotten it right? And I've talked through that. The paid parental leave for state employees. We got that right this legislative session, so thank you all for supporting that. We want to see more of that because it's just for state workers. We need to see that across the board. One of the things that really struck me as we was putting this together was around compassion. Smart, compassionate policies work, and my colleagues here have talked about that. We are human beings. Moms and birthing people are human beings, and we need compassion. Dr. Owens really brought that home. I sit here as a mom, just like Representative Summers, Tamika James Jones, so many of us. We sit here as moms who have also experienced this in our own personal lives of the heartbreak that can happen, or even the good experience of having a doctor who says, I hear you, I listen to you, let's get you what you need. And so these are some of the things. But with continued investments in Mississippi, it can lead to a better South in which maternal and health and economic security is the standard. We have a gold standard around that. I also want to just bring up, while we're here in this room, we got a baby in here. Right? We got little Denver in here, which I think really helps sets the tone, right, for what we are really working towards, right? Is we're working to make sure that little Denver and all the little Denvers that come behind her have an opportunity for a good, healthy start, right? That is what we want, and that moms are also able to care for their babies. And we make accommodations to where the workplace supports the mom. So we have a Robin in her workplace, me, at Mississippi Black Women's Roundtable, she's able to bring that baby with her to work, right? We want to begin to set that kind of standard across Mississippi. So, you've heard me talk about legislative priorities. We've been talking about it for a couple of months now. We want to come back to you all this legislative session, and we want to continue to introduce that paid, want you all to introduce the paid family and medical leave legislation from last year. We want to ask that you all continue to, we need Medicaid expansion. Like we need it. Invest in the child care infrastructure. And we need to strengthen Mississippi's equal pay law. Right now, we have a law in the book that is not strong, and it actually hinders moms and women. One of the things in this law that it says is that we need a law that does not rely on salary history. We know that Black women in particular continue to make less on the dollar than white women. And so we need a law that says that employers cannot look at her prior salary history because it was already based in gender discrimination. And so we need all employers, we need a state law that says no employer can rely on that. And that means she can have her whole dollar, because right now she doesn't have her whole dollar. So I just want to thank you all so much, the Mississippi Black Legislative Caucus, for always supporting the work that not only Mississippi Black Women's Roundtable does, but also so many of our partners. So thank you so much. I just want to say we also have, for those that want the references to my presentation, there's a QR code that's also up here. And I'll give this to Representative Summers so that she can get it out, and you can always contact us at the office. Thank you so much.
Ms. Welcham, I had to fight for this mic, so I'm gonna make this question.
Okay. I understand. Woo!
Thank you for all that you do. And look, I try to be as transparent as possible. As a man, where's the messaging? What kind of messaging are we going to get? Because I've been indoctrinated today with a lot of new information. Yeah. And it makes me more aware of what we need to do for maternal health in the state. But what kind of message would you recommend to the leadership or to the policymakers who are mostly men, mostly white men, to get to them in their thinking what needs to happen and what policies need to be introduced?
One thing I would say is that we really embed this work in storytelling. And storytelling is so important. I think the more we have dads and men talk about their own experiences, because you all too have been touched by the loss in your own families. We need more of your stories to come forward. Right now, Mississippi Black Women's Roundtable have a storytelling campaign. 6 Dimensions, Mississippi Center for Justice. We would love to be able to connect with you to lift up these stories. I also think that it's great that we can have these kind of meetings in districts where we know there are high, maternal mortality rates and infant mortality rates. Like, bring these hearings out the Capitol and put them also in the districts to ask for men to participate in them, but then having you all story. I think you're the storytellers, right, in this. So to me, that's one of the ways in which that can happen.
Thank you, Chairman Kareem. Thank you, Ms. Welchland.
Thank you.
To your point, I think we have some members that would be willing to be a part of that campaign. I think that would be helpful. And then the caucus has been going across the state doing town halls. We just had one in Greenwood. We've been to Laurel as well as Gulfport. We have Columbus and Holly Springs coming up. And so we will take that into consideration, bringing the hearings to community. But we got to move along, and I'm going to ask all of the speakers on this next panel to come forward, please. Dr. Talia Strader, who's a licensed professional counselor, Monica Stinson, who is the Senior Program Director of the Mississippi Perinatal Quality Collaborative, Dr. Helen Beatty, who is the Community Impact Director for American Heart Association Jackson Metro Area, and Dr. Ballard, who is the Director of the Mississippi WIC Program. If you all could sit at the end of the table, and you can present in that order, and then members, we will do questions at the end of all of their presentations. Thank you. So we can have two here, one on either side, please. There you go. Thank you. And we will begin with Dr. Strader.
Good afternoon, to the members of the Mississippi Black Caucus and the community. I want to thank you all for having this discussion. I am from the gateway of the Delta, Yazoo City, Mississippi. Yes, I am a proud product of 39194. There was this thing when I was growing up. I'm a missionary Baptist product as well. And so in the summer times, we would have revivals. And with revival, sometimes we would have just one guest for the whole week. Sometimes we would have different guests each night. So I feel like the Friday night pastor, because everybody else has really paved the way with having this conversation around maternal mental health. I am overjoyed about this conversation. I told the representative from Jones County earlier, thank you for even having the conversation, bringing dads to the conversation, because they are an important part of maternal health. I am a licensed professional counselor. I've been doing this work for about 25 years here in the state. I love what I do because oftentimes people that look like me, mental health was not a conversation that we had. Let's just be honest. We don't talk about how we feel. We don't talk about those dark thoughts that we have. We don't talk about the experiences of trauma that have been generationally passed down to us. I told you I'm from the Delta, so you can understand the trauma that comes with that, whether it's spoken or unspoken. With this conversation around motherhood, sometimes there is a joy in bringing a baby in the world, but sometimes, and I think we need to be honest, it's not always a joyful situation. And we have to be honest about that as well. So I want you all to think about, if you are a mother or if you are a parent, an aunt, what did that look like when the birthing person was going through that process of motherhood? Just think in your mind, what did that look like? I had support. I had a village. But some of the moms that I work with don't have a village. And so, like Ms. Welch said earlier, think about moms who don't have child care or don't have the transportation. All of those things can be a barrier when we're thinking about maternal mental health, especially with African American women who, who here in the state have, that 1 in 7 suffer from a mental health illness. So let me bring that into context for you. I am a pregnant mother. I may have just gotten furloughed. That's my financial. I am up at night with this baby that I am carrying, a whole human, who is being affected by my emotions as well. If I've been furloughed, I'm probably frustrated because I don't know who's going to help me pay this next bill that's coming up. I am hungry because my SNAP benefits are about to be cut off as well. So you can see how just that one traumatic thing that has happened in life encompasses all of these things that are going on that make me a whole person.
and my mental health plays a part in that. It is so important that we make mental health, integrate mental health into the services that we provide when we're talking about mental health services. And I'm not talking about just asking a screening, having a professional in that office that is integrated so we can have what we call warm handoffs. That's one thing I like about the clinic that I work in at the VA. I am integrated within the women's health clinic. So when it has been identified or she has requested help, walk down, knock on my door, hey, we have someone. The veteran is not the woman is not walking out of the office with a paper referral, because 9 times out of 10, if you don't make that connection right there, it's not going to happen. And then she's gonna suffer in silence longer. I like what Ms. Cassandra said also about having the fathers to be a part of that conversation as well. You all are a part of the journey of pregnancy. You may not be carrying that baby, but emotionally you are carrying something as well. So you have to be a part of that conversation as well. When we think about policies that can help, again, thank you, like everyone else has said before, we want to thank you all for expanding the postpartum care up to 12 months after the baby has been born. But some of the things that we also need to look at is transportation, which we've heard echoed in the halls earlier today as well. Just the stigma around mental health needs to have a conversation. And oftentimes moms, may feel like they're isolated. One of the programs that I'm working with Jackson State University, Brittany and I are both working with the maternal mental health, the Maternal Center for Excellence at Jackson State University with the Mommy Care postpartum program. And we're doing a lot of work in the Delta area in 5 counties right now. So we're gathering research and data to see what works. One of the things that I've been tasked with is having an online support system for women. So for 10 weeks, we have mothers who have just delivered or within the last year go through this program where they're learning about how to advocate for themselves, because sometimes when we go into the doctor's office, because that doctor has a white coat on, we feel like they're the expert. Like I tell my clients, I am not the expert of you. I may have the degrees, but I can't go into your skin to know how you feel, and that's where you come to the table and let me know what's going on. Learning how to even communicate their needs. Oftentimes, as women, especially Black women, we have had this silent message that has been given to us about we are strong. I tell my clients, Superwoman lives on the Justice League. You can take the cape off and burn it if you want to. But we have to sometimes give people that permission because we feel like that's what we're supposed to do. Birthing a baby is a hard thing, whether you do it naturally or whether you do it through C-section. It's hard. Emotions that come with that can be very hard as well. And I'm not just talking about the baby blues that can happen 2 to 3 weeks after. I'm talking about postpartum depression or anxiety or psychosis that can come along with those. And so being able to wrap around services for moms, I think, is very much so key and important when we're talking about maternal health care. I want to thank you all again for allowing me to even speak to mental health and what that could look like, and being here and being a part of this session. Thank you.
Ms. Stinson, you ready?
All right, good afternoon, everyone. My name is Monica Stinson. I am with the Mississippi Public Health Institute. I'm a senior program manager there, but I manage the Mississippi Perinatal Quality Collaborative. And so thank you all for having me here today. So my talk is a little different. I am going to talk from the perspective of working with birthing hospitals in Mississippi on quality improvement. And so I don't want to get too far off my slides because I will get off, but just a little bit, I want to ground the conversation so that I could bring it into all of the information that was presented before me today and really hone in on collaboration and how it all works together, how we all should be working together. And many of us who have come before, many of the individuals that have, and organizations that have come before me work with our Perinatal Quality Collaborative. But I have to give you some background information so that you can see how it all works together. So as I mentioned earlier, I'm with the Mississippi Public Health Institute. We are a nonprofit organization where our mission is to engage in partnerships to help our Mississippians. So what is, and I know you may say, what is a Perinatal Quality Collaborative? So we are a part of a national network of perinatal quality collaboratives around the United States. We are a grant-funded program. We are funded by the Centers for Disease Control and Prevention, and also we receive some foundation funding to help us with our work. So we are thankful for that. We were actually established in 2014, so we've been around for 11 years doing this work with our birthing hospitals in our communities. And so we are just really around to help connect our hospitals, our providers, our community partners statewide to strengthen our care systems and to improve outcomes for families. So on the screen, you'll see our team, and as you can see, Dr. Bell, who was here earlier, she's our maternal clinical consultant. We have representatives from the neonatal team. We have nurse trainers. We also have patient and community engagement advisors. And then we also have a steering committee that is made up of doulas, social workers, mental health professionals, many other maternal fetal medicine specialists, and many other disciplines, work in substance use, and many other disciplines that help guide our work through the collaborative. And as I mentioned, our perinatal quality collaboratives are multidisciplinary teams that work across our birthing hospitals in Mississippi and our communities to improve maternal and infant outcomes. We focus on collaboration, communication, and connection, bringing those together who care for moms and babies to drive measurable improvements. So what is quality improvement? What does that mean? Quality improvement is our foundation. It is a structured, data-driven process that helps identify gaps in care, test those solutions, and measure progress. So we collect data on those specific projects that we may be working on. The goal is to make care safer and more consistent. And it's our hope to create system change. Our PQC is divided into 3 divisions. We have the maternal division, the neonatal division, and the patient, family, and community engagement division. And each division focuses on, as I mentioned earlier, focuses on quality improvement and linking clinical care with community resources. And so that's where I wanted to make sure that we, I want you to understand that we are working to help bridge our community with our communities with our clinical teams and providers. And how we do that, we work with, as I mentioned earlier, many of the organizations that are here, 6 Dimensions and many others. I won't start calling names, but many others just working to help our providers and our healthcare teams understand the resources that are out there. A lot of times we've heard our nurses and providers say, well, we didn't know that resource was out there. We didn't know that, there was a mental health peer support group that we could refer our moms to. Or where do we send our moms to get diapers? They didn't know about the diaper bank in the Delta. And so our goal is to help our providers know where the resources are so that they can refer our patients out. So I know we've talked about data a lot, so I'm not going to prolong the time with data. I'm going to skip that slide. But I want to talk about some of the initiatives that we've implemented over the last decade. And it's based on a set of evidence-based practices that were developed by what's called the Alliance for Innovation on Maternal Health, AIM. And so you probably saw that in Dr. Bell's slides earlier. So it's a set of standard practices that we utilize to help practice standard of care and quality and safety. We want the births to be safe. We want our moms and our babies to be healthy. And so if our clinicians and providers are, you know, I'm not gonna say unsure, I don't wanna take away from their clinical expertise, but sometimes we have physicians that just were not trained in a certain area. And so we know that evidence is ever evolving. So we provide that information. We put it in their faces. And so we customize toolkits for our birthing hospitals. We utilize the practices and the standards from the national organization, but we customize it for our birthing hospitals. So it looks like us. We design a team or bring together a team of experts to help design the toolkits, and that is just their guidebook. They already know how to deliver babies and take care of babies and all of that, and mothers, but it's a guidebook. It's a guidebook. So this next slide, it just shows you the AIM bundles that we've implemented over the years. And as Dr. Bell mentioned earlier, the cardiac bundle is our next AIM bundle that we will be implementing along with the Mississippi State Department of Health and other partner organizations. And what that means, and when we say implement, our role is to provide technical assistance to the hospitals on these AIM safety bundles. So any resources that we can bring in, whether it's bringing in birthing balls and paying for those. We don't have a lot of money with the PQC, but we utilize our little small amount of money and working with our partners to help purchase items or purchase resources or materials, or we design wallet cards or you know, posters for the units so that it's easy access, so that they don't have to dig and find the information. It's readily available. These bundles have been focused on some of the most critical areas affecting maternal outcomes. And so, as you can see, severe maternal hypertension, obstetric hemorrhage, hypertension and heart, the initiative to support vaginal births, and our last bundle was the postpartum discharge, which a lot of work has gone into. You heard about our mothers dying postpartum, and so really working very hard to provide resources that are accessible to our mothers and families. And so through this work, we have seen significant impact. Our hospitals have strengthened their clinical protocols. They've enhanced coordination among care teams. And that's really what it's about, is bringing teams together. So we, you know, encourage the hospitals to have those huddles and bundles and talk about what happened, what worked and what didn't work, and what can we do to improve it for the next mother or next family. And so even though implementation has not been without challenges, of course, we know that our hospitals and our teams, you know, they're suffering turnover. It's a lot of turnover, and then it's just not enough capacity to help implement some of the work that we're asking them to. So our goal is to just provide that additional support. It's not to be burdensome and bringing in extra work, because this work is for the care and the safety of our moms and our babies. And I want to talk a little bit about respectful care and how we embed this into every AIM bundle that we implement in basically all of our work. Respectful care is the foundation of everything that we do. It's about ensuring that every birthing person is treated with dignity, compassion, and cultural sensitivity through their care journey. By centering the patient's voice, we promote shared decision-making, and this is something that I want to bring up. One of the speakers earlier talked about ensuring that our moms and our families know how to make informed decisions about their care, not just what somebody tells you, but how can I make an informed decision about my care and my journey, and what does that look like by developing a birth plan? So we're providing resources on birth plans, on shared decision making, and also informed consent. You're not just gonna do anything to me without my consent. And so ensuring that our families know that they have those rights to make sure that they understand the care that's being done to them. And that's where the next part of our work comes in. I want to talk a little bit about one of the tools that we're using to help drive quality improvement in the hospitals, and it's the Quality Interactions Project. And so what is that? It is a patient-reported experience survey. We are collecting data to understand patients' experiences. And so what they, how was their experience in a hospital? Because we talk about systems and the broken systems, but how do we fix that? We have to go there and understand what happened. And so Brittany is one of our doula ambassadors. She's helping to collect data along with other ambassadors around the state, helping us to collect data on hospital birthing experiences. We're going to share that information back with the hospitals. It's our hope that they use that information to make their care better, or if they have good care, or if they provided good care, continue to do that. And so the last slide, I know I have to go on, that's our mom survey. So the last slide just talks about our policy pathways that we encourage. Of course, all of the things that were mentioned earlier, just supporting the full implementation of AIM safety bundles, because that is the standard of care and practice. And then talking about quality improvement, that's needed for a lot of things, because what you're doing is testing, and if it doesn't work, you're doing it again and testing it until it's done right. And of course, expanding support for maternal mental health and substance use, and strengthening accountability through our patient voice. We talk about our patient voices, that's very important. So that's all that I have. I will end, and that's my contact information. Thank you.
Thank you, Ms. Stinson. Dr. Ballard.
Good afternoon. Can you hear me okay? Good afternoon to the chair, the members of the Mississippi Legislative Black Caucus, and distinguished guests. Thank you for the opportunity to speak today on issues that strike at the heart of who we are as a state, the health and survival of Mississippi's mothers and babies. My name is Dr. Jamisha Ballard, and I am speaking to you today as a public health advocate and nutrition professional who has spent more than a decade working in maternal and child health programs across the state. As we've already heard today, Mississippi has one of the highest maternal mortality rates in the United States. And in Mississippi, Black women in our state are 3 to 4 times more likely to die from pregnancy-related causes than white women. Many of these deaths are preventable. When we look closer, we see that the causes are complex: limited access to care, chronic diseases, social and economic inequalities. But they are not insurmountable. One of the most under-recognized and underfunded parts of this conversation is nutrition. Nutrition is not a side issue. It is a cornerstone of maternal health. Every stage of pregnancy, from conception to postpartum, depends on adequate nutrition for both the mother and the baby. Poor nutrition contributes to preterm birth, low birth weight, gestational diabetes, and hypertensive disorders, all leading causes of maternal morbidity and mortality and infant mortality in Mississippi. Beyond statistics, what we see in our communities tells the story even more clearly. In Mississippi's Delta and region and rural counties, many mothers live in food deserts, miles away from grocery stores that offer fresh produce and prenatal-friendly foods. Too often, the most accessible options are convenience stores and fast food locations. So when we talk about maternal health, we cannot separate it from food access, economic security, and community resources. I've worked with mothers who want to eat better, but they face real barriers. As we know, in postpartum nutrition, which is the months after birth, is just as critical as prenatal nutrition. Yet most mothers lose support after delivery. This is where policymakers can make a real difference. By bridging the gap between clinical care and community nutrition, we can save lives and improve outcomes. So some policy priorities for maternal health include: 1, integrate nutrition counseling into maternal care systems. Every OBGYN and delivering hospital should have access to a registered dietitian or a nutrition educator as part of the core care team. Nutrition counseling should be standard, not optional, for all pregnant and postpartum women, particularly those at high risk for chronic disease. 2nd, reimbursement for lactation professionals. Certified lactation counselors and international board-certified lactation consultants are a vital part of the healthcare team for mothers who plan to breastfeed. Breastfed infants have lower incidence of infections and chronic disease, and mothers who breastfeed have lower instances of diseases like breast and ovarian cancers. But mothers need help. Most women who breastfeed do not have access to affordable lactation support once they leave the hospital. 3rd, expand paid medical leave for all families, not just the ones that work at state agencies. Paid family and medical leave is not just a workforce benefit, it is a maternal health intervention. Across the United States, data shows that women who have access to paid leave experience better physical recovery, lower rates of postpartum depression, and stronger infant bonding. Yet, Mississippi remains one of the few states without a comprehensive paid leave policy. 4th, invest in food security as a health strategy. Policymakers can support partnerships between local farmers, community organizations, and hospitals to create food as medicine initiatives. These programs provide healthy food prescriptions or produce vouchers for pregnant and postpartum women. Imagine if every woman leaving a postpartum or prenatal appointment also left with fresh produce or a grocery voucher. That's public health in action. 5th, and finally, collect and report nutrition-related data. We need consistent data collection on nutrition indicators like anemia, gestational diabetes, and food insecurity across all maternal health programs. This data can guide funding, resource allocation, and targeted interventions for counties in Mississippi that are most in need. We cannot forget that nutrition also impacts mental health. Postpartum depression is one of the leading complications of childbirth. Studies show that deficiencies in key nutrients, such as omega-3 fatty acids, iron, vitamin D, can worsen mood disorders and anxiety in new mothers. By supporting mothers' nutritional needs, we are also supporting their emotional well-being and resilience, which directly impacts family stability and child development. So as a public health practitioner and a daughter of the Mississippi Delta, I have sat with mothers who are doing everything right. They're attending appointments, following advice, loving their families fiercely, and still falling through the cracks of a fragmented system. They remind us that maternal health is not only a medical issue, it is a moral and community issue. When a mother dies, the impact ripples through generations. Children grow up without mothers, families without anchors, communities without the women who hold them together. Mississippi has the expertise, the compassion, and the innovation to change this story. We can build a system that values prevention as much as treatment, that funds community programs as much as hospitals, and that listens to mothers as much as it studies them. Nutrition must be seen not as charity, but as policy, a matter of health equity, of racial justice, and of human dignity. By prioritizing nutrition in our maternal health strategies, we can move Mississippi from the bottom of the rankings to being a model for how states can save mothers and strengthen families. Thank you for your time and attention today.
Thank you, Dr. Ballard. Dr. Beatty? Good afternoon. Can you all hear me? Good afternoon. Thank you, Senator Summers, and certainly to the Legislative Black Caucus for the opportunity to come to share today. I kind of chuckle. I feel like I'm coming last, but I'm the glue for everything that has been said here today. I represent the American Heart Association. They have me as the Senior Community Impact Director in Jackson, Mississippi, but I cover Mississippi. So when we talk about issues of maternal health, morbidity, mortality, we already know that cardiovascular disease is the leading cause of death. The American Heart Association is the one who sets the pace with everything that's going on with your blood pressure, your heart attack, and your stroke. In 2021, there was in the issue of circulation, it was established at that time that the etiology of the issues that are going on relative to these deaths was high blood pressure. And I'd like to say that I am the resource, again, that connects the dots. I work with all of the community health centers in the state of Mississippi that see integration and implementation. When we're talking about expanding Medicaid, you got to, for maternal health, we have to have evidence-based blood pressure cuffs prescribed from pregnant mothers, because the average cuff that's coming off the shelf at Walgreens, we know everything is going on with the body at that time. Everybody's nodding with that. There are prescribed blood pressure cuffs for pregnant women. So what do we do now when we talk about resources and bringing resources to bear as the American Heart Association in my role? I work as a part of a development team. I sit with these women who are meeting with Atmos Energy, you name the funders in this area, to talk to them about how we activate their money in this community. What do we do? Dr. Burst so amply talked about network to make that a what? The gift that kept on giving, that they got food every month. We bought the refrigerators, not just refrigerators, but I partnered with Hotel and Restaurant Supply to provide them what? Commercial grade, timed, temperature grade refrigerators and freezers, steel shelves. We don't need the plastic shelves that are in what? In Walmart, because the canned goods. I put that opportunity in and encourage them to what? Retrofit their EHR records. We're making this sustainable now. Who knows the issues that you're dealing with? Your provider, right? Your high blood pressure, your diabetes. So we were able to get them to retrofit their EHR records to make this what? Sustainable. So a part of the triage process now, everybody is asked the evidence-based questions. Have you had a meal? When is that, what is the food situation like in your home? This is just in generality, but there's a prescribed list of questions. And when they look at your situation, if it's hypertension, if it's diabetes, they're able to on-site, based upon the medical condition of that mom or that patient in the clinic, prepare them a food bag that walks out the door with them. These are the types of resources that we need to bring into communities. We're looking at self-monitored blood pressure. When I talk about self-monitored blood pressure, that's the science of what we're doing. Every mother is not able to get to their provider every day. So what do? Providing them with a blood pressure cuff that we then teach them the appropriate 7 to 9 steps on how to take their blood pressure. They're able to keep a diary and share that information with their provider. So blood pressure cuffs are important. They can't get to the provider. Where are we putting the blood pressure cuffs? I need them in the church. I need them in the library. I need them with Dr. Burst, who we were able to give 50 blood pressure cuffs to her program on last year. But not only her program, I mentioned that I work with not only community-based organizations, I work with who? The 21 community health centers across the state. I'm happy to tell you today that at least about 10 of those health centers, I have put in at least 200 blood pressure cuffs. Whitney, are you in here? Where are you? Whitney Batiste, we contracted with Whitney Batiste talking about mental health and well-being to get us what? Mommy boxes that were designed by for the American Heart Association. It was all branding, you know how that works. But bringing in community partners then to look at, hey, we need to be able to provide well-being exercises for them, diaries, teas, just comforting types of things. We provided moms with the blood pressure cuffs. Then we connect them with what? The resources through the pantries. I have put in food pantries in Jackson Hines Comprehensive Health Center, the Utica Clinic, Mallory Health Center, the Maternal Health Clinic in in Lexington, exactly. We've done it at Jefferson Comprehensive Health Center. Several health centers across the state that we've put in food pantries in order to connect dollars and food. Yes. Winding it up, resources are critical and important. They're critical and important. It's the policy thing that I think that we could leave here with is being able to do some of the CPR training with moms when they are leaving, just like you're training in them on the how to use their car seat, because a lot of these sentinel events with their babies are happening after they birth. Thank you for your time. I'm happy to get with several of you to talk about a number of the projects that I do. I touch the lives of a lot of folk in Mississippi. Unfortunately, but I'm thankful to have this opportunity to be able to tell you that that's happening. Thank you.
Thank you. Thank you so much, ladies. We need to quickly go to our final speaker, and I'm going to hand the mic to Representative Tamika James Jones to introduce her. Thank you so much, ladies.
Ladies and gentlemen, I introduce to you Ms. Chanel Ball-Green from Belzona, Mississippi. She's a proud graduate of the class of 1992 of those Humphreys County Cowboys. Chanel is an evangelist. She has served as a radiology technician. She's a professional barber and stylist. She loves her community, and she believes in fighting for the well-being of the people for the state of Mississippi. But most importantly, she's a mother, and she's a proud mother of the most beautiful face there is that we shall see on this screen. Ladies and gentlemen, if you will, I introduce to you Chanel Ball-Green.
Hey, y'all, how y'all doing? Look, I almost said, praise the Lord, everybody. Yes. I tell you, I'm a little nervous. I've been up since 3 o'clock writing this down because this is very important. This right here started a fight within me. How many know that a lot of the hardest fights start when somebody dies? A lot of development start when a person cancer, somebody died. Then somebody took the fight. Somebody died, a car accident, mothers getting drunk driving. Somebody passed away. My fight started when my daughter passed away, Harmony Ball Stribling. Before I get started, I'm not going to prolong. It's short and sweet. I'm trying to keep myself together. But let me talk a little bit about Humphreys County, about the Mississippi Delta. You know, we heard the things. But Humphreys County and Mississippi Delta have 91% graduation rate of high school students. Also there, that 70% of us travel outside of our towns and communities to work, employment. I worked at the University of Mississippi Medical Center 12 years. Also, in doing that, guess what happens? Our money go to other facilities, other gas stations, other grocery stores. So they look at us like we're not doing what we need to do, but the problem is somewhere up front not getting done and doing what they're supposed to do. We have nurses and nurse practitioners within our town, at least 21. My niece, 2 nieces, one just graduated from nursing school, RN. One is in school right now. I have a few classmates that's nurse practitioners now. And they said we don't have the medical staff, but it comes with the funding. They also working in other towns. he talked earlier, Dr. Abney, he's from the Delta, about bussing out. We don't understand bussing out hurts us because we need it here. And I say all that to say this: Humphreys County sit in between Sunflower, Washington, Holmes, LaFleur County. We are the heart of the Delta. 16, Highway 61, 49, 12, 7, 3. Depends on which way you come in. Some of those towns are closer to Humphreys County than they are their own town. But to us, our drive to the hospitals are at least 30 to 45 minutes. So bringing necessity need is not just for us, it's for those ones that's closer to our county line than their own hospitals. Thank y'all so much for having me. I surely appreciate it. Harmony, right there. To all the representatives, I thank you so much for allowing me to speak today on the behalf right here of the Legislative Black Caucus. I come before you from Belzoni, Humphreys County, a place where our hearts are full, but our health care is empty. A place where the difference between life and death can be measured not in miles, but in minutes. I didn't know what to say when I was asked to speak here today, because how do you find words when your heart has been shattered? How do you describe watching your child's life fade because help was too far away? See, Harmony was born June 21st, 1991. She came in this world without me even helping. Guess what she was born at the University of Mississippi Medical Center, which I went in an hour and 25 minutes to birth her. She simply made her debut strong and determined, just like her name. Harmony was a beautiful soul. To some people, she was just crazy. She was a soloist, an educator, a wife, and a mother. A lot of people don't have insurance. We talked about that. A lot of them don't have the necessity of the food or the wig. She had that. But what Harmony didn't have was the facility. She met Byron, who was her husband at the time, in high school. They grew up together, fell in love, and built dreams together. She already had a son from a previous relationship, a sweet boy, Jaden, who adored her, went everywhere with her. But when she married Byron, she wanted to give him a child of his own. Then, that was her heart desire. Then came the diagnosis of endometriosis, and everything changes. The pain was more than physical. The dream of giving life to another child suddenly seemed impossible. Surgery took her ability to conceive naturally. Right there, there's mental pain. And with it, a part of her laughter. Yet with faith and perseverance, she and Byron saved and financially found the means and was blessed with monies for IVF. I'll never forget that day, her smile returned, and she said, "Mama, I'm going to give Byron a baby." Every doctor visit was a journey, 55 miles one way. I was so blessed today to meet several people that was in Harmony life. I'm sorry. I didn't know Dr. Owens was one of her physicians. Dr. Kitchens had a conversation with her. Even before that, they remembered her. Being here today to talk to you was more than just telling my story. It was like a period to the 3 dots. I got a chance to meet women and men that was there with my baby, even in her final months. Every time, still she went with joy. On June 21st, 2021, Harmony turned 30 years old. She was radiant, glowing with life, preparing for the baby Harper. Everybody knew her. Her due date was July, full term, 9 months. Her baby shower was overflowing with love and hope. Harmony ended up sharing her journey on social media, which shocked us. But she said she felt an urge to share her IVF journey and her mental status of not being able to give her husband a child. People followed her from Africa to London. They was contacting her, want to know mental status, financial, what it really cost. And she shared it all on Facebook. So it wasn't just us that was waiting. It was a community. Then came the 4th of July, 2021. Less than a month after her 30th birthday. Late that night, Harmony began to feel unwell. She was diagnosed with preeclampsia. But for the last month, her vitals was normal. She and Byron got dressed and headed towards Yazoo City, Mississippi. 25 minutes drive. But in an emergency, that drive became a lifetime. Before they reached the hospital, Harmony began to seize. She had a heart attack. Byron called ahead desperate. Because in the Delta, you don't wait on the ambulance. Because the ambulance could be in another county. Because they have to serve at least 3. Only to be told there's no ambulance nearby. So on the side of a dark Mississippi Highway, 49, in the gravel and blackness, he was instructed to stop and start CPR on his wife. Can you imagine that moment? A husband, a young man who has loved this woman since high school. And he would have been here today, but he had death. His grandfather passed away. Now he's kneeling on the side of the road, trying to save her life with his bare hands, praying for help that never came. By the time the ambulance arrived, it was too late. Harmony and Harper was gone. And the words that still haunt me were the ones whispered through the tears of even the nurses that night. If only she had oxygen, if only the ambulance had come sooner, they both could have made it. If only. 2 words that echoed in my soul and in my heart and in the hearts of too many of Mississippi families. Since that night, Byron still has to drive past that stretch of highway where he lost his wife and child. Their son, my grandson, will soon graduate, and the seat where his mother should be will be empty. Every holiday, every milestone, every laugh in our family carries the shadow of her absence and the words whispering, if only. And I ask you to think about your own families, your own daughters, and your sons, your wives, your granddaughters. What would you do if their life depended on a 25-minute drive. And there's no hope, there's no help along the way. What if you hear the words, if only? I didn't know what to say today, but I knew I had to show up because I don't know what another mother, because I don't want another mother to hold her child's obituary instead of her hand. I don't want another husband to kneel on the side of the road crying for help that never comes. I don't want another child to walk across a graduation stage and search in the crowd for a face that isn't there. Harpers County has fewer than 8,000 people. We are surrounded by counties, Yazoo, LaFleur, Sunflower, Holmes, and Washington. Yet too many of us must still travel out of town for care. When 70% of our people have to go elsewhere for basic necessity or emergency service. Our communities are not sick, it's bleeding. When I think about what happened to my daughter and Harper, my heart breaks, not just as a mother, but as a member of a community still crying out for care. And it makes me think of what the Apostle Paul said in Philippians 2:1-5. If you have any encouragement from being united with Christ, any comfort from his love, any tenderness and compassion, then make my joy complete by being like-minded, having the same love, being one in spirit and one in mind. That's what I'm asking of you today, that we come together with the same love, the same tenderness, the same compassion, that we look not to our own interests, but to the needs of others, to the mothers who are still here, to the babies yet unborn, to the families who praise that it won't be them next. Because this isn't just about health care policies, it's about value of life itself. It's about choosing compassion over convenience, unity over division, and service over silence. I'm not here just for harmony. Harper, they gone. I'm here for my neighbor. I'm here for your kids. I'm advocating for the person that don't feel heard, underpaid, feel like the community is talking about us, what we lack and not what we have. She had all the insurance. She had the education. She had the marriage. She had the future, the pregnancy. So you look at that child, you said, they got it. But she didn't have help. She didn't have the facility. They had her vote, but she didn't have their help. We need emergency care, ambulance, hospitals, and hope, so that no one else has to hear if only. So that when a mother cries for help, a husband sighs in silence, we can say everything that could have been done was done, and the rest is left to God. Thank you for listening, not just with your ears, but with your heart. And I pray that when you return home tonight and sit around that dining table and you think about how blessed you are to live in cities where the hospital's around the corner, or you could pick up a phone call like Dr. Owens said. Because I was one of them. I was pregnant working at the university, and I had preeclampsia, and they let me off work to go right across to the women's unit to walk. But what if I was back home? The Bible tells us in Proverbs 31:8-9 to speak up for those who cannot speak for themselves, to defend the rights of the poor and the needy. Today, I'm asking that we do just that. Not as politicians, constituents, but as mothers and fathers and grandparents, uncles and aunties and cousins. and human beings who believe that every heartbeat deserves a chance to be heard and every mother a chance to hold their child. Thank you.
What a testimony. Thank you so much for your courage, for your willingness to be here today and share the story of Harmony and Harper. This is deeply personal, and we know that we have much work to do. I want to thank all of the speakers for being here today. I want to thank them for giving us the information that we need so that we can take that back. And our goal through the Mississippi Legislative Black Caucus, ladies and gentlemen, is to create our own omnibus package for the 2026 session. And we will take all the information, all the stories, all the data, all the policy proposals and solutions and package that into legislation, because we know that we must treat this issue. This is a life and death issue, and it deserves the attention and the resources so that we can see change be possible in the state of Mississippi. Thank you to Representative Tamika James Jones, to my colleagues, to our partners, and I will give it back to our chairman to close us out.
Thank you, Representative Summers. If you all would, give Representative Summers and Representative James Jones another round of applause. This was an awesome hearing. It was a critical, it's a critical need in our community. I want to thank everybody for their heartfelt testimonies, and to the presenters and to our partners. We want to thank Six Dimensions, Mississippi Black Roundtable, March of Dimes, State Innovation Exchange. I want to remind you all that tomorrow we're going to be doing a digital dialogue on voting rights. We have a serious issue coming up before the Supreme Court. If you all are not familiar with it, it's a situation that can decimate black representation and voting power in this country, particularly here in the South. And we're doing a digital dialogue. They can, how can they go to the Mississippi Legislative Black Caucus website, and you can register to participate in this. And remember, let me just say this before we close. The Mississippi Legislative Black Caucus, we're on the move, we're working. We are the voice of the 1.2 million black folks here in the state of Mississippi, and we are representing you here at this Capitol. And we carry you to each and every piece of legislation that we introduce. We're thinking about you. But we can't do it by ourselves. We need your input. We need your voices. We need you to contact your legislators, even the ones that are not here today. Let them know that you were here, and ask them to help you stay informed on what's going on. Again, thank you all so much to the members who are participating in person and online. We're working, and we're trying to represent the people here in Mississippi, particularly black folks here. There's an element in our country, particularly here in the state, that are trying to turn the clock back. They're trying to turn it all the way back to 1875. So we have to be vigilant, and we have to continue to put the issues out to the forefront so you can make an informed decision on these issues that are pertaining to you and your families. Again, thank you, Representative Summers, Representative James Jones, for this important dialogue and this hearing that we had today. And pray for these families that are experiencing these issues. And look, we got something coming up Saturday where they're cutting SNAP benefits. It's going to affect over 400,000 Mississippians. And when you go back to your hamlets and villages, you need to be having these conversations with your leaders in your communities, whether it's the church, the elected officials, your organizations, on how we are going to fill in the gaps. How we are going to fill in the gaps. We can't depend on other folks to do what we can do for ourselves. So I encourage you as you leave here, after we eat, to have that conversation in your communities. We're going to end with prayer. You got a comment to make before we get out of here? Representative James Jones, please.
Thank you so much. Again, we've taken a moment to educate. And now it's time for us to activate. Let us activate and elevate. Just want to take a moment, if you will, Mr. Chairman, and thank you all so much again. To my sister-in-law, my forever sister-in-law, Chanel, thank you. Thank you for sharing with us. So bold. And we just pray that God will help us through this journey. But again, we've taken time this morning to educate, to elevate. Now, let us activate. Thank you so much.
Thank you, Representative James Jones. Do you have any comments?
Thank you. We're going to, after we pray and be served, we're going to show a very short film. It's only about 11 minutes. I was introduced to this film called Water Angel, and it tells a very powerful story about a couple's pregnancy journey. And so we hope that while you're eating, you'll also enjoy the film. Please like us on Facebook, follow us on Instagram, so that you can stay up to date on some of the future programs that we have coming forward. Representative Denton.
Before we turn over to the gentleman from Warren, I know you all don't hear this too often from elected officials, but we love y'all. We do. We do. We put the armor of God on every day coming to this Capitol knowing what we're up against. But we do it because we love the people, particularly our black folks here in Mississippi. So y'all remember that as y'all go back home. The gentleman from Warren, please take us out with prayer and bless the food.
All right, let's go to God in prayer. Father God, we come before you with a bowed head and a humble heart. Before we go any further, Father, we'd just like to thank you. Thank you for this morning awakening. Thank you for allowing us to witness what we have witnessed here today. Father, we ask that every word goes forth and falls on good ground. Father, we know that we're going to place it in you, Father, for we know that if we place it with you, then you will multiply it. You will see that it goes forth and do good. Father, we can't do nothing, and I mean absolutely nothing without you, Father. Father, so we lean and depend upon you to help us fight the good fight. Put on the whole armor of God.
Yes, sir.
The whole armor, Father. We ask that you lace up our bootstraps, gird our waist, Father. Put the helmet on our heads, Father. And for the sword of justice, Father, go forth and do good in your name. Father, for we know if we do it in your name, Father, then everything will be all right. Father, we ask that you bless this food that is put before us. Ask that it be nourishment for our bodies. And when this life battle has been fought and the victory has been won, Father, we ask that you say each and every one is a place in that kingdom. We ask these blessings in our Son, Jesus' name, for his sake. Let every heart say amen.
Amen. Amen. Yes, sir. Thank you all. I came over to tell you. Let me make sure the mic on.